Is it? Mike. One, two. Then our personal work click చేసి మీరు ఎంటర్ అయిపోతుంది ఆటోమేటిక్ అయిపోయి ఫిజికల్ అయితే పెన్ డ్రైవ్ లో తీసుకోవచ్చు చెప్పండి.
Good morning, everyone. Already we are learning late today. So, I announced the formal opening of A2 of this international conference today. We are already late as per our schedule. And Dr. Bekele was supposed to join us from Rwanda. He is having some urgent tasks. So he will be joining maybe in the afternoon. And we are having two guest speakers from USA in the afternoon, or keynote speakers. We are having Dean School of Medicine from UNICAF here, Dr. Chile. We are having representation from the Association of Zambia. I welcome both of you. And directly we will switch over to the technical sessions. So in this hall, we will be dealing with public health sessions. LT1 we will be having medicine and clinical sciences. LT3 we will be having business management and IT. So I formally announce opening of sessions day 2.
Please, can we put our hands together as we welcome our first speaker for today, Lilayi Campus.
Face. Please. Okay.
Okay, so good morning, everyone. My name is Lilayi Campus. I'm a student under public health. I'm doing my master's. Today, I'll be running you through my proposal entitled the Availability and Stockouts of Essential Medicines at Chipata First Level Hospital.
Okay.
All right. Apologies about that. Technical difficulties. However, let's continue. So the background to my research, essential medicines are critical for the prevention and treatment of common health conditions, and their uninterrupted availability is definitely a cornerstone of quality health delivery. So despite efforts by the Zambian government, you will realize that the Zambia Medicine Supplies Agency, which is ZAMSA, and the introduction of electronic logistics management systems, stock out of essential medicines still remain a big challenge in the public health facilities, including the first level hospitals. So my research objective is to assess the availability and stock out of selected essential medicines, of course, at Chipata First Level Hospital, and the period is from January to December 2014. My methodology, I will be using a descriptive cross-sectional study. This will be a retrospective review of stock control cards for the period January to December 2024. And my sampling will be purposive, where I'll use the tracer medicine that they use at Chipata First Level Hospital. And for my data, I will use a structured checklist to extract the data. The expected results. Obviously, there will be some variations in essential medicines availability. Some medicines will show consistent availability, while others will show recurrent stockouts. Stockouts expected mostly in antibiotics, antimalarials, and medicines used in the management of chronic diseases. Trends may also reveal that some months will have higher shortages. Okay, so what are some of the implications of the findings after doing the research? So definitely, if you don't have availability of stock, there will be disruption of patient care due to delayed or incomplete treatment, increased out-of-pocket costs on the patient. So it means instead of them having found medications readily available at the facilities, it means they'll need to use their own money to purchase those medicines. And then there will be reduced confidence in the public health care system and utilization of public health facilities. Because you'll be telling yourself, why go to these public health facilities when I go definitely I'll not be able to find these medicines. Evidence of supply chain inefficiencies in procurement and forecasting. Then need for improved electronic logistics management system use and routine stock monitoring. In conclusion, we are saying consistent availability of essential medicine is crucial for quality healthcare. Need for improved forecasting, procurement, and coordinated supply chain is vital. Better use of the system, which is our electronic logistic management system, and routine monitoring of monitoring reduces stockouts. It will also support progress towards universal health coverage. Some of the keywords in my research proposal would be availability, Chipata First Level Hospital, where the research will be conducted, essential medicines, stockouts, supply chain management, and ZAMSA, which is the Zambia Medicines and Supplies Agency. Thank you so much. Questions from the audience or the candidates?
Thank you so much. Okay, my question is, why did you pick deposit sampling method instead of
Okay.
I hope you picked my question.
I did. Thank you so much.
All right, thank you.
Okay, so the reason why I picked purposive is because I'll be using a tracer drug list which already has the essential listed. And these are the ones that they use for the first level hospitals across all the first level hospitals. So I wanted to stick to the medicines that they use, that we know that these definitely should be able to be found at these facilities. So that is the reason why I picked the positive suffering. Thank you.
Any other question?
You mentioned that you're going to assess the cost, out-of-pocket costs the patients and the relatives incur. I just wanted to find out what methodology you're going to use to actually do that.
If my memory serves me right, I did not say I was going to assess the out-of-pocket. So my assessment and the objective, if you notice, I said I was going to assess the availability and stock out of medicine, not the out-of-pocket of the clients. Thank you.
Right, thank you. I think I'll just follow an out-of-pocket question that asked. So my question was, because you said there will be increased out-of-pocket from the patient. Have you tried also to maybe factor in that there's also the other aspect of out-of-pocket that can be relieved by NEMA? Have you tried to factor in NEMA as well in your research? Because I believe first level hospitals are also under NEMA, and once a decision has been given, then the out-of-pocket expenses that can be incurred by the patients and then covered by NEMA. So are you also factoring in that in your research?
Not really, because not all patients are on NEMA. So you find that most of the people that visit these facilities, I'll stick to the first level hospitals, most of them are not in employment. So, yes.
But thank you for saying that they are not in employment. But again, the NEMA, on NEMA again, so there's a part of formal and informal clients and your members. So there's members that are not employed, but marketeers are also under NEMA. And if you check the database that NEMA has now, majority of the patients that are going to be working at Chipata level 1 right now, I would say maybe 70% of the patients are under NEMA. So this is why I asked the question to say, have you factored in that NEMA is also trying to help in those regards?
Okay, so on that one, I'll not lie, I did not factor in, because my target was the people that are not on NEMA. So if you say that, maybe we might try and factor in and see how this would definitely affect the people that will not find the medicines readily available, and the fallback being NEMA, are they going to really be helped in that regard? Thank you.
Yeah, thank you so much. The question is basically on the period that you're doing since January to
December, yes.
Then in your statements, I hear you say, we realize that actually some months have got more stockouts than others. So now, what inference are you going to draw? More especially that only a period of 1 year. So, is it enough or sufficient to draw a situational analysis or trend analysis based on 1 year? That's sufficient.
Definitely, it is sufficient because that is a full year, and I think it will provide enough data sets. So 1 year will be sufficient.
I'll give you an example. If the period, let's say, from April to June, mostly is a commodity. out of stock. So can you generalize
For that particular year, yes, we will say from this period to this period, yes, definitely this was out of
so
stock
after
and will
getting
not
that for that year, how does that help you in the preceding years in terms of forecasting?
In terms of forecasting, then we look at the supply chain schedules. Is it because of SAMs are being not being on time when they do their schedules? So maybe we'll try to look at that because there are instances where maybe the central store is scheduled to deliver every second week of the month, and that month elapses. You find that maybe they deliver in the last week. So that would definitely affect your stock. So it means when you're supposed to have that stock, the period that you're stocked out, you will not have it because it was not delivered.
Why I asked you that question? Because outside the box, give an example, 2019, when we had COVID, azithromycin, for instance, was on the rise in terms of consumption because of COVID. So when you get that analysis from that year, you can't actually translate it to the preceding years because there was a pending epidemic that actually happened. So do you factor all those factors in terms of research?
So in terms of that, the low stock of azithromycin that you mentioned, it was due to demand in that period, isn't it? So all things being equal, it means that if the demand goes up, definitely we will stock out and we will state why this was stocked out. And this is why we are carrying out this research.
So basically, what I'm trying to help you is that when you have one single year, you can't do an inference to say these drugs during this period always are consumed more than these other previous seasons because you're only looking at a period of one single year, unless you have a very period, let's say 5 years. So you have to do a trend analysis and say, okay, mostly during this season, costs have moved because of the code, because of ABCD and ABCD. But in one single year, it is very difficult to draw an inference and then generalize and say, during this period, this is what happens. Thank you.
Thank you so much. That is well noted. But for the purpose of the study, I chose to go with 1 year, looking at the time limit that I have. Thank you.
My last question.
Yes.
I believe your source data, your primary source data, is that right? The retrospective review patient. Is that right?
Stock up and stock availability, so not just
Yes.
stock out. Yes.
Yeah. So you do not have any other source data from staff.
No. So this is purely from the stock control cards.
Yeah. So now in your conclusions, your findings say that there was a poor utilization, for example, of process, and there's also a lack of staff capacity. How would we be able to assess that resource data? How did the staff at the hospital? It was very difficult for you to make a conclusion about how well the system is being used, how well staff are being trained, actually interact. So I just want you to think about that, and maybe that may be another additional part of your study that may be able to enhance your finding or the conclusions that you are proposing.
Okay. That is well noted. Thank you so much.
Round of applause from Thailand. We now have an online presentation from Nancy. Political justice.
Precious.
So precious is we have data. Having problem with our online we need, so again we'll have another patient from the around the world. Student to get 7 minutes participation and 3 minutes question and answer.
Introduced, I'm Dr. Janet Mega from the District Health Office. I'm here to present my proposal, prevalence of loss to follow and contributing factors among patients evaluated for tuberculosis in the Lusaka district. So as you all may be aware, and it also affects, especially in Africa, low and middle income countries. In Zambia, Zambia is not so Zambia is among the 30 countries that is affected by tuberculosis, and Lusaka district is one of the highest districts with TB-related morbidity and mortalities. And so, despite all the efforts that have been made trying to control TB, we've noted that there's still some challenges that are related to patient retention. And this usually leads to high rates of loss to follow-up. And so this really affects the national TB control. Next. My main objective is to identify and explore factors that are contributing to the loss to follow-up, as well as understand the prevalence of loss to follow-up in Lusaka district as it is currently unknown. My specific objectives is to identify the challenges among patients diagnosed with TB that leads to loss to follow-up in this in Lusaka district, and also determine at which phase these patients are lost. So there are those patients who start in the intensive phase and those in continuation phase. We want to know at which phase are these patients lost and understand what is our prevalence, and also explore the factors that are contributing to these losses. Thank you. What methods are we going to use? So this will be a descriptive cross-sectional study, which will employ a mixed method approach. So we'll have a qualitative side as well as a quantitative side. So the qualitative side, we're going to interview 7 healthcare workers in these selected facilities. We have 7 facilities that have been selected. So 5 are first-level hospitals, 1 zonal hospital, and 1 urban center. So these are high-volume TB diagnostic sites. So that's where we will get all these cases from. So we're going to interview the 7 healthcare workers who know and have experienced this TB, who see these clients who are TB patients. And then the quantitative side, we're going to have a sample size of 374, and we're going to get these cases, the loss to follow-up, all the TB patients, loss to follow-up patients, we're going to get them from the TB registers, as well as the district health information system, which is DHIS 2, and we're going to analyze them from the period 2024-2025. We're going to analyze all those cases, and we'll use a simple random sampling method. So the expected result, we want to be able to see what is our prevalence in Lusaka district, as it is not quantified. So we want to know what is our prevalence of loss to follow-up for the loss to follow-up in our district, as well as understand what are the associated factors that lead to these loss to follow-up from the point of view of our healthcare workers. And we're hoping that as we do this study, we'll be able to inform strategies that reduce loss to follow-up and also improve our TB treatment outcomes, thereby contributing and controlling the TB cases in Lusaka district. Thank you.
Conduct your qualitative interviews. Because there's one important aspect we haven't mentioned when it comes to data collection. And also sample size. How did you arrive at the sample? Sampling method. I want you to kind of explain a bit. How did you pick that sampling method? Because there are other people talked of a risk study, and she said she used the POSIF. And the presentation also, there's some retrospective aspect there. The sampling method seems to be very different. So I just want to get a clarification. Instead of the possible computers, why did you do? But what's happening?
Okay, so thank you for those questions. So for the qualitative, I'm going to do an interview with the 10 close-ended expressions that we're going to interview these clients for the healthcare workers. Yes, and for the sample size, well, for the sample size, I used it was based on the target population of the TB, notified TB cases that were notified during this period, which is 14,664, and with a margin error of 5%, as well as the confidence interval of 95%. That's how I calculated my sample size. So I used, because I have a population, the simple random method was the best to use in this case.
Good morning. Thank you so much. That was beautiful. As you presented, I was trying to think. Lusaka is mixed in terms of economic status, demographic features, and other things. So when you are looking at your study, why did you decide to just get the whole Lusaka as a whole? Don't you think that if you had maybe taken a smaller unit, let's say for instance, you say in the peri-urban areas, or in the low-income areas, or the high-density areas, depending on what you think this problem is actually more prominent, I think it is going to be more helpful, because it will be very difficult for you to actually generalize the findings you're going to find, because other statements won't fit into settings, depending on the characteristics and features. Maybe the you think helped you to do your research, at least to be a bit more specific on the areas and just generalize the whole study, because Osaka is very big.
Yeah, I agree with you. Thank you for that suggestion. Yeah, I think.
Thank you very much, Dr. The question I have is with regards to the interviews that you're going to conduct. You're only interviewing staff. Why aren't you interviewing patients? Because patients will give you more information about why maybe because they're at the funerals, deaths, no money to the TB drugs and so on and so forth. Don't you think you needed to interview patients, actual patients?
Thank you for that question. Yes, I actually thought about that, but patients are not really readily available, and because of time constraints, I opted to interview the healthcare workers to get that view from them. And also for healthcare workers, they can have an idea of what the patients have really told them concerning the why they miss their appointments.
When you look at availability, I think in the data registers, their contact numbers there. Also, you can have a selection criteria to randomly sample and get some people that you can actually do an in-core interview and find out the challenges that they face. So I don't think that approach is valid in this respect. So you may just look at it and see how best you can manage your presentation. Thank you.
Thank you.
Round of applause for her.
What is that? That's one. Yeah, now she's
Okay.
we can share. Yeah. Yes.
Hope you are able to
Be sharing.
hear me. I'm trying to share. Okay, are you able to hear me? Hello, are you able to hear me? Are you able to hear me? Because I think I can hardly hear anyone. Please.
We can
if you are
hear you
able.
very well.
Oh,
We
great.
can hear you. You are very audible. Thank you.
Thank you. So can I start my presentation? Thank you very much. My name is James Zulu or Dr. Zulu. I will share hope you, am I still sharing? Because I think on the screen I can't see it. Am I still sharing? Or somebody else is sharing?
Already there.
Hello? Okay. I've maximized my screen. So now I don't know, are you able to see it? Are you able to see my screen? Okay, great. Can I go ahead? Yeah, because I can't hear you. If you're able to hear me, okay, please. I've seen a thumb, so I'll go ahead. I hope I'll be able to get the questions because I can hardly hear you. Thank you very much. So as I said, my name is James Zulu. I'm a student in public health. I work for the Center for Infectious Disease Research in Zambia. So I will share my research, the study which I was doing on the factors contributing to teenager pregnancies at Kanakantapa Basic School. Oh, okay. Okay, let me stop. I've been told that I should stop sharing. Stopping sharing. Is it okay? Who's going to share? Let me stop. Okay, I've stopped sharing. Is somebody going to share? IT, please assist.
Can you drop a message?
Oh, okay.
Please yes, it. Better breath. But it is not.
Good morning. Can you hear me?
Yes, you are loud and clear.
All right. So sorry, Dr. Zulu. I think mine was put in to start. I don't know if I can begin.
Okay,
If I can get a thumbs up.
I think it's
All right.
fine. It's
Okay.
fine. Yeah.
All right, thank you so much. And good morning to our esteemed conference participants. I think I would just like to say all protocols observed. My name's Precious Kabungo Mumbi, and I'm honored to present this abstract, and may I say, titled Community-Based Volunteer Engagement in Cholera Preparedness and Response. This is a case study of Kanyama Township in Lusaka, Zambia. This research co-authored, or may I say supervised, by Professor Patrick Chanda and Professor Lawson Fanu Osimapuka, and of course presenting it myself as the presenting author. Really, this study evaluated the contribution of community-based volunteers to cholera preparedness and response in Kanyama Township. And Kanyama Township, if I can share with everyone, is those not familiar with Lusaka, it's one of the most prone areas with recurring outbreaks driven by poor sanitation, overcrowding, and limited access to clean water. Despite really repeated interventions, I think many of you will attest, those of you who were in Lusaka in 2023, 2024, when we experienced the worst cholera outbreak, which saw over 22,000 people getting infected. We saw over 700 people losing their lives to that outbreak. And so, which tells us that there are some, community level preparedness gaps that still exist. So having said that, if I can proceed, really, I saw firsthand the potential of community-based volunteers who are really embedded in these communities, and yet, often they're really the first ones to respond, but their roles, again, still remain underutilized and poorly coordinated. So this study really evaluated their contribution and how we can explore how they can be better supported to strengthen Zambia's cholera elimination strategy. If we talk of the methodologies, I chose a mixed methods approach to capture both statistical trends and lived experiences. Can you hear me? Yes.
Good morning. Sorry, we could not see your presentation. We could only hear your voice. So do you mind over?
Oh, you still cannot see it. Okay. Let me try. Okay, my slide, I was showing that it's presenting. I'm not sure why it's not.
No, it was. We were able to, yeah.
You were able to see it? What were you not?
And then put it in slideshow.
Okay.
Yes. Just a minute. Yes. So I'm introducing you to the audience. This is Precious Mumbi, one of our master faculty students. So Precious, you get 7 minutes for presentation and 3 minutes for question and answer. So in total, you get 10 minutes. And the best.
Thank you so much. Please confirm that you're able to see it in slideshow now.
Yes, we can see your slides.
Thank you. All right. Thank you so much, Ms. Niza. If I can start from the beginning. And again, I'd love to say and ride on all the protocols to say I really appreciate and welcome everyone to listen to my abstract. And co-authoring this was Professor Patrick Chanda, as well as Professor Lawson Fanu Osimapuka. If I can proceed on just to introduce that the title of abstract, really community-based volunteer engagement, cholera preparedness and response, a case study of Kanyama Township of Lusaka, Zambia. Now, this study really evaluated the contribution of community-based volunteers to cholera preparedness and response in Kanyama Township. Kanyama Township is really one of the Lusaka's most cholera-prone areas, and with recurring outbreaks, particularly driven by poor sanitation, overcrowding, but also this most important one, which is the limited access to clean water. And despite these repeated interventions, we saw a very, the worst outbreak that Zambia has ever experienced back in 2023, 2024, the cholera outbreak, which really revealed to us some of these persistent gaps in community level preparedness. So really, I saw firsthand the potential of, what these community-based volunteers have because they're embedded right there in the communities and really often the first to respond. And yet their roles still remain underutilized. Please let me know if the slides are not moving, because from my end, they're moving. So the methodology, I chose a mixed methods approach to capture both statistical trends and lived experiences. CBVs were very instrumental as well in the data collection, ensuring trust and cultural sensitivity. If I look at the quantitative data, it was collected from 5,391 people using the COBO toolbox administered by 22 trained CBVs. If I look at the qualitative data came from key informant interviews and focus group discussions. Now, sampling, if I may add, was stratified by cholera risk zones. And the data was analyzed using the SPSS for statistical tests and thematic coding for qualitative insights. Again, if I have to touch on the ethical approvals, of course, obtained through TAUREC and, of course, Lusaka District Health Office. Now, in designing the study, I also applied Fisher's formula, because you can see here that the study population is really huge, looking at the total Kanyama residents. As you can see, of 562,726. So I really applied Fisher's formula in really, if I can say, to determine an appropriate sample size for the population under investigation. So which is what resulted in the inclusion of the 22 CBVs as well as the 5,391 individuals. If I can, again, I think I have shared this part, I'll skip this. If I look into the findings or the results, now the findings really confirm that CBVs are really vital connectors between communities and health systems. So they improved awareness, reduced infection risk, and were highly, highly trusted. And however, of course, they first faced certain challenges such as limited resources, lack of formal training, unclear roles. But really, if you have to also read what I've shared here on the gender aspect of it, we can see more females playing the role of community-based volunteers, which is significant overrepresentation and suggesting this central role in caregiving and health advocacy, if I can just pick out just a few. If you look again on the quantitative data, 98% of respondents were aware of cholera symptoms. Sanitation access was almost evenly split between pit latrines with slabs, flush toilets, but 5%, you can see here, used, if I can see 5% used unimproved pits and 8% still practiced open defecation. Again, just in a nutshell, nearly 70% of households were exposed to flooding. As you know, we do have this flooding situation with the blocked drainages, if there are any. But also, we also look at the positive part where community appreciation of CBVs stood at 79%, showing that CBVs are highly trusted and accepted in their roles. Again, back on the results, I think I have touched mostly on these aspects, but just to also mention this 69.5% reported flooding, which correlated with the cholera risk that I mentioned even as I began in the background. Again, CBV education reduced infection probability from 42.7% to 28.3%. If I go into the statistical evidence, households educated by CBVs were significantly more likely to correctly identify key cholera symptoms. Again, significantly less likely to hold misconceptions such as wrongly associating muscle cramps with cholera. Again, this was validated by a chi-square test, that is x squared equals to 452.18 with a p-value less than 0.001. And this really, what this indicated, if I can really add, it indicated a highly significant association between CBV education and accurate symptom recognition, which tells us more on how CBVs play a pivotal role in early detection and also community-based surveillance. So the data really showed like households reached by CBVs were significantly more informed about cholera symptoms and less prone to misinformation. Again, if I really now go into just maybe touching more on the statistical evidence, which was echoed by local health leadership, who described CBVs as the eyes and ears on the ground. And I thought I would bring this, to light here. Again, if we look into more results, we look at the unimproved sanitation, which showed that the odds ratio equals to 3.01 individuals exposed to poor sanitation were basically 3 times more likely to contract cholera compared to those with improved facilities and improved facilities. Again, if we look at the aspect of non-tap water sources, if we look at the non-tap water sources on the odds ratio equals to 2.65, really showed us that those relying on unsafe water sources had 2.65 times higher odds of infection. So these odds ratios also indicated as strong, statistically significant predictors, if I can put it that way, of cholera transmission, really consistent with some of the global findings on WASH-related vulnerabilities. Now, however, if I can really add to you that the numbers only tell part of the story. You see, as one CBV in Kanyama even shared that, some people don't listen when we tell them to clean up their yards or surroundings. They joke that, we are compound nurses and should additionally help them get rid of the waste. What this quote really illustrates, it illustrates the social dynamics and resistance that CBVs face. So where health messaging is sometimes met with humor, deflection, or even burden shifting, it still underscores the need for not just infrastructure, but community ownership and behavior change. So I thought I would add this as well. Again, if we look at the CBV-led education, reduced infection probability from 42.7% to 28.3%, as I had also shared. Now, their intrinsic motivation was strong, but really, without formal support, sustainability really remains still at a risk. So integration into the health system is crucial. And our multivariate analysis really revealed that exposure to CBV-led education significantly reduced the probability of cholera infection. So from 42.7% among unexpected individuals to 28.3% among those who receive CBV education. And this effect, again, if I just talk briefly about what it meant, this effect was statistically validated by a chi-square test, again, indicating a high significant association. And the large test statistic, extremely low value, confirm that the observed reduction is unlikely to be due to random variations. So these findings, colleagues, really underscore the crucial role of CBVs in community-led health, education, and outbreak prevention. If I go to the conclusion, really, the now hypothesis for me, I think it states that CBVs do not significantly contribute to cholera preparedness and response in Kanyama Township, and yet the alternative hypothesis really posits that CBVs do play a very significant role. So this study really tested these hypotheses using both the quantitative and the qualitative data. So all 3 objectives also were met. CBVs improved early detection. They faced, operational challenges. They demonstrated potential for sustainable impact. And if I really proceed forth to just say and share that the study really recommends formal integration of CBVs into preparedness plans, regular planning, and resource support. So if I was really to repeat this study, I would expand definitely to other townships, even widen the target population, but also, improve survey coding and also include seasonal tracking. So what I would add in here is that what this research has shown is that, cholera preparedness in informal urban settlements like Kanyama cannot solely solely rely on infrastructure alone or emergency protocols. It needs to be rooted, if I may add, in community agency. Community-based volunteers are not just responders. They're the heartbeats of the local resilience. So their proximity, their trust, their commitment, it makes them really indispensable, and yet they remain under-supported and under-recognized. I will jump the limitations, but just to again add on, building on the insights gathered from Kanyama Township, the recommendations I've shared on this slide, they aim to just translate evidence into action, strengthening cholera preparedness through community-centered strategies. We always keep hearing in Zambia that, we hear people, we say cholera is like an annual event for Zambia, but, what is it that we can really do to kind of really be more proactive and really engage these key cutters? So these recommendations are not just operational, they are transformational, and they call for a shift from reactive outbreak response to proactive community-driven resilience, if I may add. Again, just before I get into the acknowledgements, I would still want to add that what this research does, it affirms community-based volunteers are not just foot soldiers. They're the backbone of resilience health systems. So by investing in their capacity, recognizing their lived expertise, embedding their voices in policy, we move closer to a future where preparedness is not, again, just reactive. So if, I would love to just really acknowledge the support, huge support from Professor Patrick Chanda, Professor Lawson Simapuka, Ms. Niza Rien, for the constant push, the support. Again, I'll be failing if I really failing in my duty if I fail to acknowledge Texila American University staff, our student mentor, Ms. Mavis, again, Lusaka Provincial Health Office, the District Health Office, but also, most importantly as well, the CBVs and the residents of Kanyama who participated in this and continue to be there on the ground. And definitely my family, I wouldn't have done this without them. So I'll end here and thank you so much. I hope I was audible because I can't hear or see anything right now. Thank you. Okay. Okay, thank you. Is it mute or I hand this over to the audience out there? Ms. Niza?
No.
Okay.
Thank you so much. How are you, madam?
I'm fine, thank you. How are you?
I'm well, thank you. You're talking, it's Mr. Mambo, National Coordinator for the Public Health Association.
Okay.
My question is, I was making presentations. I think I didn't get your objectives of this study.
Okay.
I could hear you were talking about the engagement of CBVs, what they can do and the like. But I think throughout your presentation, what I expected was for you to give us statistical data to actually compare the results in cholera management before these communities volunteers were engaged and after they engaged. Or management of CBVs. What did that translate to? Look at your presentation. What did really are we looking at?
Okay, thank you. I didn't get part of your question. I got the part where you're asking regarding the objectives and what we are looking at in this research. Am I correct? You were breaking, but I think I got some.
Sure. Maybe just help me on that one. What are the objectives of this study?
All right. Okay, no, thank you so much for the questions. So the objective really of the study was to evaluate the contribution of community-based volunteers to cholera preparedness and response in Kanyama township of Lusaka, Zambia. And in particular, I don't know if you had also wanted to get more about why this particular study?
What I wanted to find out here, is that we're trying to look at the contribution of CDVs in cholera preparedness.
Yes.
So
Yeah.
now, what statistics did you collect in terms of those different variations? When we did have these CDVs and when we engaged them, what are the numerical?
Okay, if I can hear, I don't know why there's so much noise and echo, but okay, no problem. So basically, what this study was really trying to bring about is that, look, we have these community-based volunteers. And when we talk of community-based volunteers, we're talking of members of communities who are properly trained, who properly have access to, let's say, in a response, in an outbreak, they have access to specific facilities where they're able to just help bring the population affected, to seek care. Also, it's back to the behavior change aspects. These CBVs are trained, and so they're able to also be, can I call them agents within those communities that are able to just share some of this basic knowledge that they have. For instance, simple things like boil unsafe water you're not sure of. As you know, cholera, when we speak cholera, we think of feces in water, in our food. So it's basically really having these cadres who are really trusted community members, speaking to me as a next door neighbor to say, neighbor, I've seen you getting water from the well. Are you making sure that this water is safe? Are you chlorinating it? So, looking at having these CBVs just really within reach, but at the same time, ably, can I call it, empowered, and at the same time, being able to share their knowledge so that we really avoid these outbreaks from occurring. So without such a structure, the community-based volunteer structure, I think would even be seen worse within our communities. Already right now, we are in the month of November. This is the season for cholera, when rain season sets in. But at the same time, it should be an ongoing thing and not just wait for rains to come before, communities start experiencing outbreaks for us to start thinking of, we should be utilizing community-based volunteers in this way. But, proactively putting them in a system where they are already embedded there, they're able to adequately support within the communities to prevent some of these disease outbreaks such as cholera. I hope I've answered your question. Sorry, I can't. My study used both quantitative and qualitative. I used the mixed methods approach, which captured both those statistical trends and also those lived experiences. So what I did also, I used some of these CBVs who were very instrumental as well in the data collection. So I used the mixed methods approach. So both quantitative and qualitative.
Any other questions?
I hope I was audible.
My name is I'm a clinical officer and public health student. Okay, I worked during the cholera outbreak in 2018
Our camera.
and 2021. So my question is, seeing that your research is quantitative, like, do you have data, like, when the CPVs, like, do you have data, like, when the CPVs were involved, like, did we see any changes in trends, and then do you have data to back that up? Because cholera has an ongoing thing in so the involvement of CPVs, do you have any data to say, okay, when they were involved, like, we had more intervention than before? Let's put 2018 as a whole.
Thank you so much. I hope I could hear your questions correctly. Asking if I have the data showing that if CBVs are involved, this is the kind of results that we would see, right, within the communities. So this is why this research, was done, to say if we're able to employ some of these recommendations that have been made or coming out of this research, where I did work personally with the CBVs down in Kanyama Township, and also saw firsthand, even using the whole Kobo Collect tool. So, the Kobo Collect toolbox, if I can call it that, it uses real-time data. So, for instance, during an active outbreak, you have CBVs visiting the different households within their communities, and they are able to, speak to community members in real time. And what this Kobo tool actually does is share this data directly. Let's say, I think you mentioned you're from the district health office. What this data would do is feed into that database, which will show you that, okay, there's this outbreak here, and we do need to respond. So if a CBV reaches a household, finds, family members perhaps, have cholera, or, having this persistent acute watery diarrhea or vomiting, and they're able to already alarm or send, signals to the next referral system, which of course, as you know, is something that would cause for, a reaction, or will cause for some action to be taken. Say, we need to respond here, or what do we need to put within this particular area within Kanyama? Should we put out some, what do we call it? Some oral rehydration corners or points where people can quickly access clean and safe water and already get some ORS. So it really would help this intervention. So in terms of having that data, not yet having it at this point, because this is definitely a study that has been, instituted, proposed, to look at, to say, if really looked into, taken into consideration with the recommendations given, this would be a game changer in really just trying to be more proactive when it comes to active cholera outbreak situations. Thank you.
I think we will stop taking questions regarding this presentation that we can have, because we have over 20 different types. So a round of applause for Precious.
Thank you.
Thank you so much for presenting today. So our
Thank you
next
so much for having
me. Is Dr. Jess.
Thank you. Let me just share.
Dr. James, just to let you know, you have 7 minutes to present, and we're going to have 3 minutes question and answer time.
Okay.
You can go ahead.
Thank you very much, moderator. Thank you. I would like to acknowledge my supervisor, Madam Niza Lynch Mwanza, who has been there to make sure that this research takes shape.
slideshow. Put your presentation in slideshow.
Oh, yes. I've already put it. I don't know whether it's showing that side. Is it showing? It's in slideshow.
Okay, you can go ahead.
Okay, thank you. Yeah, so I will.
Yes, you can go ahead.
Thank you very much. So I'll present my research where we are looking at the factors contributing to teenager pregnancies at Kanakantapa Basic School in Chongwe District. And I would like to acknowledge my supervisor who has been there to make sure that this work is done in time, Madam Niza Lynn Sumanza. So the background to the study is that globally, teenager pregnancies are high, especially in sub-Saharan Africa, Zambia inclusive. And the teenager pregnancies has a major public health concern with far-reaching consequences, both for the girls themselves, their families, and also the community at large. This study examined factors contributing to teenager pregnancies at Kanakantapa Basic School in Chongwe District. Of course, with the four specific objectives of identifying the causes of teenager pregnancies, examining the socioeconomic factors, assessing the peer pressure and social influences which causes these teenager pregnancies, and of course, identifying major sources of these. So the key drivers, as I've alluded to, is that it includes peer pressure, poverty-limited parental guidance, and lack or limited reproductive health information and cultural practices. The findings suggested to lower a dropout and improve the health, and also to cut the poverty cycles. Main studies exist, and this is where the purpose of this study. A lot of studies have been done on teenager pregnancies, but very few have used the mixed methods, especially in rural areas, which has left a gap in understanding the dynamics and the cultural norms which exist in those rural areas. So this research fills that gap with the results of targeted interventions and ongoing future studies which will be done. The methodology used, the study used a descriptive cross-section design with mixed data. So apart from just using the cross-section design, we had to use it with mixed data so that we have both the qualitative and quantitative, and 200 respondents, which included the pupils themselves, teachers, parents, and community members participated in this data. And you appreciate that when it comes to teachers and the parents and other key informers, we had to use the purposely randomly sampling. So data was used using structured questionnaires, focus groups, and in-depth interviews. And of course, stratified random sampling was used because you needed to really bunch up, put into groups these pupils from grade 5 up to grade 12, or from the age of 10 up to the age of 19. And the teachers and parents, as I said, were recruited purposely. Quantitative data were analyzed using SPSS version 22, and of course, the qualitative data we used the semantic analysis. The study was approved by the research ethics of the Lusaka Apex Medical University. I think I was one of those who was approved by the Lusaka Apex University. The findings, as you can see, maybe in the bar charts, you are able to see that the study finds teenager pregnancy to have a manifested problem rooted in both individual, society, and the structural factors. And the peer pressure, as you can see, is coming out so much to be one of the results for these for these teenager pregnancies. And then, of course, we have poverty, lack of parental guidance, lack of reproductive health information, and cultural practices like early marriages, initiations, and of course, other cultural practices, which makes these teenagers to fall pregnant. And of course, these are major drivers of teenager pregnancies, which were found at Kanakantapa. And of course, other consequences includes the high dropouts of the high drop rates, of course, which we saw during the research, and also the social stigma and health risks like the anemia, where the girls are developing, they're having anemia, and some of the preterm birth and maternal mortality, which was a bit high as we were looking at it. And these teenager mothers face a lot of educational barriers, especially that one to they also have limited economic opportunities. As they are pregnant, they can't be productive. And of course, they are now, with that limitation, they will be perpetuated into poverty. And of course, this stigma, which they really suffer, has caused them to have that shame, that guilty, and that low esteem, leading to mental health issues among these girls. So we saw that there were a number of girls also who had mental health issues because of the stigma which they were going through. And in my conclusion and recommendation is that these findings, the findings underscore the need for a comprehensive sexual reproductive health and improved access to our youth-friendly reproductive health services and community-based intervention that will address the root causes of teenager pregnancies. Specific recommendations included the school-based programs, where we need now to go back and promote abstinence. Because right now, even when you are talking about in the field of HIV, you discover that issues of abstinence are not being promoted, but instead contraceptions also are the ones which are being promoted more than abstinence. But in this study, we are recommending that apart from programs on abstinence, contraception, and other healthy relationships are supposed to be promoted so that we have support system which will keep these mothers in school. And also one of the other recommendations that engaging the local leaders, which will be able to challenge harmful cultural norms, is also recommended, because if you can have indonors, you can have the chiefs, you can have the key people in society who are able to challenge these other key issues, which are very harmful norms, will be able to promote will be able to prevent teenager pregnancies. And of course, disseminating these results to the Ministry of Education, Ministry of Health, and other NGOs will really be able to guide a national adolescent sexual reproductive strategy, which is being recommended. And of course, I think I would like to really acknowledge the teams which assisted me to get this information from my working place. I want to recommend to acknowledge the Texila team, my supervisor, and all the advisors at Texila. The Ministry of Health, I would like to recommend them. I would like to acknowledge them at the district level and also at Kanakanta Palulu Health Center, because those were the people who were very key. And of course, the Ministry of Education themselves. Thank you very much. Hope I was within the time.
Thank you. I'll now take questions.
Yes, please. Come again, sorry, I can't hear you.
Good morning, how are you?
I'm all right, thank you.
that you found was the issue of lack of parental guidance as one of the reasons why the early pregnancies in schools, especially in the school. So whom did you interview before you come up with this analysis concerning this?
Sorry, there's some noise on that question. You said one of the findings?
One of the findings was that the lack of parental guidance. So in terms of quantifying, coming up with statistical data, who was the respondent to give this information?
Mrs. Simmons, assist me. I think I haven't heard that one.
Are you looking now?
Okay. So you said one of the findings was it?
One of the contributing factors to the pregnancies was lack of parental guidance.
Yes. Lack of parental guidance.
How did you come up with that data? So who are the respondents to this indication?
Okay. So as I said that this study employed a mixed method, which is a cross-section design, which was utilizing both the quantitative and qualitative data to correct or to provide a comprehensive understanding of these factors. So one of the things which we did that we had to hold what we are calling the in-depth interviews. In-depth interviews with the parents of these teenagers, and some of them also with the key informers like the teachers, and also we had also in-depth interviews with the health providers. And one thing which was coming out was that the lack of reproductive health information, lack of reproductive health information to these teenagers was causing them, because they were ignorant about what they are supposed to do with their health, reproductive health. And that's why this study has recommended, if you see, I've recommended that apart from issues of abstinence, we need to be able to provide contraception. Because currently, you can't go in a school and talk about condomizing or maybe talk about any contraception method. The teenagers or the adolescents, the pupils are supposed to be outside the school. That's when you can talk about these things because of the policy of the Ministry of Education. But one of the issues which came out is that there is lack of information. And also there was also lack of those. We discovered that those families which didn't have a parent, or maybe who were just maybe a single-headed family, they had lack of parental guidance, and that's where we are finding a lot of teenagers having these pregnancies. Hope I've heard your question and I've answered.
So what I'm trying to find out is that we have given us figures as to how many lack of parental guidance. So what I'm trying to find out, how did you come up with that figure?
Oh, so
there are figures there, that is statistical data. So how did you come up with the actual figure of people who lack parental guidance? Not based on policy, not based on assumptions, not based on any qualitative analysis, but it is actually quantitative in terms of how you analyze that data. So how did you come up with that kind of data? Who are the respondents in your research?
Okay, so you are saying that how did I come up with that? Because one, in terms of the percentages we used for the quantitative data, we used the SPS version 22 to give us the trends and the percentages. Hope I've answered. Thank you.
Good morning, John.
Good morning, thank you.
Yes, I have a few questions for you.
Okay, please.
I'm a bit confused in regard to your study population. You're not very clear. Who's your target population? It didn't indicate that clearly. So it's confusing, even though we're talking about the findings, you're not specific as to who your target population is. Then, I feel your results are insufficient. There's a lot missing. One, if we are talking about parents, where is the demographic data? I think it's important. You need to know the level of education of the parents. You need to know the source of income and all those things. Those are important factors that you are supposed to factor in. What else? You mentioned it was a mixed method study. I haven't seen the qualitative results. Maybe if you could answer all my questions. Thank you.
Okay. Yeah, so indeed, this was a mixed design study, which really, for me, I had to go for the mixed study design because one, it really allowed for the correction of both the numerical data and also the narratives, and also it provided a more understanding of the research phenomena in the sense that, see, the population was 200, and the primary targets were the pupils who were going at Kanakantapa, and of course, we had the secondary targets who were more like key informers, like the parents, the healthcare providers, and also the communities. And the primary target, of course, we are looking at the age of, when you look at my study document, you look at the adolescents aged 10 to 19 who attended school at Kanakantapa. And then, of course, you want to look at the secondary target, who are the parents, the guardians, who are the guardians for these adolescents, who are the teachers, who are the nurses, the community leaders. So you'll be able to see that you need to use, for you to have a complete understanding, you need to use both the qualitative, the SPSS, to analyze the trends, to analyze and to come up with those percentages like the previous the previous person asked me. And then also you need to be able now, you find out about in terms of the semantics. And as you have said, one of the things which came out in terms of the level of education, you want to understand also the level of poverty. How much are they able to spend maybe per day? So that information is collected. And that's why I had to settle for the mixed study design.
Hello, Dr. Zulu, can you get me?
Yes.
Okay, so in the interest of time, please keep your answers short, very short.
Okay.
Good morning, Mr. Zulu.
Good morning. Yes, I'm able to hear you.
Yes, I just want to take you back a little bit. In your background, you mentioned that lack of comprehensive sexual education was, it was showing that it causes teenage pregnancy. Did you try in your research at Kanakantapa to explore that area? Because I didn't see it in the results.
Okay, thank you very much. I think in the results it was coming out. Only that I think I just picked up all those, because it's one of my major recommendations. When you go to my major recommendations, that we really need to come up with a school-based program which will promote abstinent contraceptions and the health relationship. And I said that we need to improve access to youth-friendly reproductive health by, of course, coming up a comprehensive sexuality education, because it was one of the findings which we found. So we needed to respond to it. So I did.
Thank you so much, Doctor. Thank you.
Thank you.
A round of applause. Right about now, I think we're going to have a physical presentation from one of the presenters, and is physically here with us, Dr. Ali. A round of applause for Dr. Ali.
Thank you very much for this invitation. I'm here to present the burden profile of stroke in Zambia by referring patients from the tertiary hospital. You can easily Zambia getting advantage of the possibility and the facilities which allow us to understand our topic, which is the burden of stroke. Learning from the previous presenters, so I'm actually also explaining why. So our study will be ranging from January 2025 to December 2025. So for the sake of visibility, this is a review. A pilot study which can be extended 4 years, so we can get 2024, way back because it's a retrospective study. And we'll extend it to different years. Stroke burden in Zambia, a profile from the University teaching. So as I was saying, stroke remains one of the leading causes of death and disability worldwide.
Next slide, press next.
The university choose to second and tertiary sector. So contribute significantly to medical that increase the burden of non-communicable diseases such as hypertension, diabetes, combined with limited stroke awareness, which is very important. We saw in the previous presentation that awareness is very important in public health. So this is also applied to stroke. And the late presentation has made stroke a major public health concern in Zambia. This presentation provides a glimpse, update profile of the stroke cases seen in UTH, and by then, very, as I said, Zambia, getting the advantage of being a tertiary hospital. So we are going to look at Lilayi stroke methodology. As I said, it's a cross-section hospital-based study from January December 2025, and the population will be 18 years and above, admitted with stroke in December 2025. Sample size, Fisher consideration, we are expecting to have at least 46 to 50 patients. A review of patient collection will be our data method collection. CT MRI confirmation of stroke, because that is very important for diagnosis. And we'll look also at the clinical intervention. The variable which we are looking at the demographic variable. We also look at the stroke time. We are three types of stroke: ischemic, hemorrhagic, and partial. So, next slide. So we talked about the burden. Next slide. Based on 2025 hospital data, the following group are most and middle age, adults, other younger patients are increasing hypertension and HIV-related vasculopathy. Both male and female, slightly higher proportion of male. Most patients come from other Lusaka, but also leakage, we see which growth, overbelts, sudden progress, stent progress, and history. So that makes it a very good site for some people and inferring what is going on in Zambia. So the type of stroke we said it was ischemic, hemorrhagic, and transient. Next slide. So we are also looking at the major risk, which is hypertension, diabetes, alcohol abuse, smoking, obesity, HIV infection, and non-modifier factors like age and family history. So the diagnostic approach is also very important. Once admitted, patient undergo a structured diagnosis, initial assessment in ICU and active stroke area, CT scan and MRI are done, cardiac investigation are done, laboratory and so forth. Next slide. Treatment management. Management includes emergency stabilization, blood pressure, antiplatelet therapy, management and nursing care, and rehabilitation. Next slide. Outcome after 28 days. Why 28 days? Because it's long enough to have the outcome from the time when the patient has been admitted in the hospital. Some remain with moderate to severe disability, requiring long-term rehabilitation, require a more extended study, as I said. Mortality remains higher, especially among hemorrhagic stroke patients and those presenting late. Readmission is common among patients with hypertension and post-stroke. Do the awareness about stroke so that we can make those patients and
is linked to hypertension, late presentation, adequate surveillance, strengthening stroke prevention, early detection, emergency response, and rehabilitation service is essential as part of the growth. Say, these updates give us a glimpse of the evidence policy and improve care and reduce stability and death. So,
we're now going to welcome questions from the audience. Mr. Timothy.
Good morning, no. How are you? This is not okay. Firstly, I'm confused with your format of presentation. I don't know whether this is an abstract or entry, some kind of presentation from stroke. It's a bit confusing. Yeah, I've seen your methodology and other components, but after your methodology, I don't know what that is. So maybe you can just explain a bit. Then also, I don't remember seeing your objectives. Did you have it? Okay.
We have been proposing different proposals. There are different
I believe there's a format that was shared with you when presenting your work. So I expected to see the presentation in that format. Yeah. Thank you.
So we had trying to show the burden of stroke in Zambia by inferring the data collected, getting the advantage that being a tertiary and the highest institution in Zambia. It receives, as I show in my presentation, same patient from all over. So it's, by itself, by its position, it's a good site of sampling. Yeah, so of course, the study might be extended so that it gives us a bigger picture. The extent of the problem, our side, but in the interest of visibility, something extended.
Thank you so much, Doc. I think that's read a bit on Moses' points in terms of the presentation. It's very important for you to give us your objectives and then what you want to do. You have told us in your presentation that actually stroke is a burden this time around in the country, but there is no statistical data to support that. And also, stroke is categorized in different categories. We don't even know stroke is more prevalent in our country than the other, and also what factors predispose people to such kind of occurrences. So to get really the benefit of the presentation or your research, these things must come out. Because just realizing it, the way it was coming out, it was as well, it's just a lecture to tell us about what stroke is all about, how to manage stroke, and everything else. So for me, it was a lecture and like a research presentation. So I think if structure it and put it in, give us data that we're going to appreciate, and also what we intend to actually, because remember it's public health, so looking at the public health approaches that we want to use in the prevention of cancer, like the clinical part. If I were going to present this, the public health approaches must also be highlighted. Thank you so much, Doc. We appreciate the work done so far. You can improve in those lines. Thank you.
Thank you very much. So I agree with you. Yeah, and it was done on purpose because this is just the proposal of the research. So the actual research needs now to be done and be collected. So it's going to use this quality and quantity. For me, it's very simple. Quality data answer the question why? Why is a stroke? Or how the stroke happened? So we are going to yes.
So I don't need to get when you're presenting, let it come out. I can't know what you're thinking. So if you're really must come out.
Thank you.
Okay. Any other comments?
Yeah, very good presentation. I have a question. Right. How do you, I think you are a doctor, right? So how do you counsel the patients, right, regarding modifiable factors in order to mitigate the prevalence of stroke about non-modifiable factors, modifiable factors?
Thank you very much for your question. And this is very important for public health awareness. As I said, public awareness is important. One of the problems which will account in terms of management, patient will present late in the hospital. So generally, within 24 hours, it's a critical time taking care of properly for the outcome. But so we need to actually do a lot of public awareness, public information to actually educate the population, the critical factors, critical signs, so that they can come quickly when they also. So this is a public health. So when the patient presents, generally they have symptoms. So the time of presentation is very good. That's why in our list of collection we have established a questionnaire. We have also a date of presentation and date of admission, and for how long the patient is going to be admitted. So that one has been captured. Thank you.
That was a presentation. Yes, this coming to what you just alluded, I don't know whether I also in your proposal you have included how you are going to, because we need to find mitigating factors, these people are coming from the have you included in your proposal how going to go about it, and also how you are going to ensure you have, that community linkage from UTH, where the study is taking place, to wherever these patients are coming from, because they are not just coming from the community around UTH, they are coming from all over the country. So patients that need to be put in place in order for us to prevent this scourge.
Thank you very much, Mark, for this critical, because the public health is also prevention. So we need to prevent the problem which arise, especially also. So as I said, so that we can extend the study and extended approach, try to get we have some response. We have, for example, alcohol abuse, one of the risk factors. So this is something which is by informing and awareness, and also help the prevalence. So we have a link with HIV infection, especially strong young. So that's we also two other partners who are waiting already on HIV infection. Also, the fact so these are actually those according to the extent the study, as I said, but yeah.
Thank you, Dr. Ali. A round of applause for Dr. Ali. We're going to have our judges and the presenters that are here present. We will end the way of 5. So it's strictly for presenters and the judges. Thank you.
Again, learning is there. Yeah. Hello. Hello. Yeah, learning is there. Some connection problem, internet problem. So Yes, yes. Now I can do it again. Yes. You can see me talking. Yeah. So I'm ready. And now day break. Now you know. Consulting another person, their faculty. Okay. No problem. From your side, you have to. After some time, you can go. Don't get once they join.
Are we also having tea breaks?
Yes, no, actually. No, no. I also see you are observing me since 2 days.
Yes, I am. Been very busy, sir.
Because my job is, communicating with the foreign.
With the people who are online.
No problem.
Nice.
I will tell you.
Thank you. You're welcome, Doc.
Where are the bathrooms? This way.
Then I am turning in four. Okay. Oh, okay. Breakfast at Bulakasho. Breakfast at Bulakasho. All right. I said to other companies, please have fun.
No, he came and did this. Some blue stuff. On this one. No. Something he fixed it there. And this again it went.
Pretty good. Yes. Hello, coming. Okay, one minute. Okay. That's all. It's coming. No. Communicate to them. Direct. I'm going to talk to her. Yeah. Yeah. Good morning, Miss Ensa.
Hello?
Yeah, can you share your screen?
Yeah. Wait a minute, please.
Like a presentation.
Yeah. Can you share now?
Yeah. Can you maximize? Yeah.
Now, sir?
Please stay online. Yeah, we can see. Please stay online. We will shorten.
Yeah.
Shorten 2 minutes.
Yeah, okay.
Madam, Miss. Yeah. She is about to start. Wait.
Good afternoon. Oh, it's still working, right? Okay, right about now we're going to have a presentation from Hassan from South Sudan.
Yeah.
Insaf, can you get, hello?
Hello, hello.
Can you hear me?
Yeah, I hear you very well.
Okay, okay. Have 7 minutes
Sorry.
for presentation.
So, okay. Sorry.
7 minutes to present.
Yeah.
And
Yeah.
then 3 minutes for question and answer.
Okay. Thank you.
Yeah, so you can start if you're ready.
Thank you. Thank you. I will start now.
Yes.
Yes. Good afternoon for everyone here. I appreciate your listening to my abstract of my study. I'm Insaf Hassan, a registrar or a specialist of pediatric dentistry. I'm going to present my abstract study. The study conducted by me and my colleagues. Our title is Parental Oral Health Behavior in Relation to Oral Health Status of Their Children Attending Pediatric Dental Clinic in Omdurman Military Hospital, 1890. Omdurman is one of a city in Sudan, in the state of Khartoum. As we know, the oral health is an integral part of overall general health. The dental caries is a very common and chronic disease process with a significant short and long-term consequence. Some factors affecting the oral health and oral health behavior, like maternal education, occupation, age, knowledge, and attitude, although that affect insightly in the health habits to the mothers or to the parents and also indirectly to their children. The relationship between mothers' dental health and the experience of dental care in their children can be attributed to the influence of improper dietary and hygiene habits on infants, as well as also the transmission of maternal bacteria that may infect the child's oral cavity also. As published in a previous study, the dental care is mainly caused by normal flora bacteria, Streptococcus mutans in the oral cavity. Already the child birth is sterile. The oral cavity is sterile and took the bacteria of normal flora from the environment. First, who gave these bacteria for child their mothers? Parental knowledge, beliefs, and attitudes regarding oral health significantly influence their children's toothbrushing behavior. Furthermore, parental attitude positively and markedly impact the dental health and gingival health of their children. Our main objective of this study to evaluate the relationship between parental oral health behavior and the oral health status of their children. During this study also, we get to measure the care status of their children by using a score of DMFT for primary and DMFT for permanent. To this also, we can describe the oral hygiene for the children by measuring the plaque index. Also, we can define the oral health practice of parents regarding oral hygiene maintenance and history of visiting dentist. About the methodology, our study design is observational cross-sectional study. Our study population consists of parents and children attending the pediatric dental clinic. The age group for children between 3 and 15 years. All of them attended the pediatric clinic in military Omdurman hospital. The data was collected by two methods: self-administered questionnaire for parents and the examination sheets for children. Self-administered questionnaire we got from WHO modified questions about the basic oral health survey, And the examination was done by to detect two indices. As I said, DMFT. DMFT is small, abbreviated for decay, M for missing, F for filled, T is for primary, and the capital one for the capital letters for the permanent teeth. Also, we got the black index. The black, what is the black? Black is a bacterial biofilm that formed and touch on the teeth surfaces that cause mainly the gingival and dental caries, gingivitis and dental caries. The response rate, our result, the response rate out of total study population of 213 parents, only we got 199 submitted and completed the questionnaire. About the oral hygiene, we got approximately 47.2% of respondent parents clean their teeth in the morning only, once per day. And the majority of them, 92%, use toothbrush only to keeping their oral hygiene. And about the dental visit for the parents, we got 2/3 of parents, 63.8%, reported visiting a dentist in emergency, only in emergency situation. And 15.1% of respondent parents indicated that they never visited a dentist. About the oral health status of the children by measuring the DMFT, the majority of examined children, 84.9%, exhibited fair oral hygiene that is moderately, which is a mean accumulation of plaque is visible with naked eye. And about the DMFT score we got for a permanent, we got 2.9 score. And for a primary, we got 33.3 score. That indicated, according to WHO measure for this age group, it is indicated moderately status. So that there is a significant statistical association between parental frequency of tooth brushing and also child frequency of tooth brushing. Also, we got 23.6% of graduated parents, their children clean their teeth twice a day, while 32.7% their children clean teeth once a day only. There is a significant statistical association between parents' education and frequencies of cleaning child teeth. Also, 67.3% of children who had a fair oral hygiene, they brush their teeth alone without supervision from parents. Our conclusion, despite the high level of education among the participant parents, which consisted predominantly of mothers, their influence on their children's oral health was largely inadequate. The findings suggest that mothers exhibited limited knowledge and suboptimal practices regarding their children's oral health. A high prevalence of dental caries among children serves as a significant indicator emphasizing the critical impact of parental knowledge behavior on maintaining oral health. Our recommendation, a program for maternal dental education should be designed in collaboration with primary health care providers, so that to enhance the mother role in her children's oral health. These initiatives should involve dental professionals and public health institutions in educating both parents and their children. Thank you so much. Any question? Thank you.
Anyone from the audience? from the audience? Maybe check outside?
There is some noisy in audio.
So they're not from the online participants as well. Okay, so okay,
Sorry.
Let's give applause to Mr. one of our faculty members as he does.
Thank you so much. Thank you.
when they are very young and don't want to experiment, have boyfriends, and so on. So multiple sexual partners is an issue right now, and also inconsistent condom use. That's what we're talking about, pre-exposure prophylaxis, the injectable one. So oral PrEP has faced adherence and stigma challenges, right? You find that people forget to take the medication. So long-acting injectable PrEP, introduced in Zambia in February 2024, offers a bi-monthly, but now we know that it's given every 6 months, which is a good thing. Okay? So, injectable PrEP is promising alternative, but its success relies on students' awareness, acceptance, and willingness to utilize it. So that's what I'm assessing the knowledge. Also, if they have access and if they are willing to take the injectable PrEP. Yeah, so my main objective is to assess the knowledge, attitudes, willingness to uptake injectable PrEP among university students in selected public and private universities in Osaka. So specifically, I'm assessing the level of knowledge about injectable PrEP among university students in these universities that I mentioned. Then also I'm examining the attitude of university students toward the use of injectable PrEP, and also to determine the willingness of university students to uptake the injectable PrEP, and if at all they are access again. The next slide. Yes, so my methodology study, which combined both quantitative and qualitative survey, looked at by analyzing quantitatively. I used focus group discussion among students aged between 18 and 25. So my sampling method, I used two. I used stratified random sampling method and convenience, because with the stratified, this specific age group that I'm looking at. Then when we talk about convenience, it's about the place where the students are found. I know that I'll find these students in universities like this one. So my sample size was calculated using Cochrane's formula of sample size calculation, which was 460 students. Data analysis, I will use SPSS version 24 to do the descriptive statistics and associations. I use chi-square test and also logistic regression. Yeah, so for qualitative data, this one will be analyzed semantically, okay, using semantic analysis, okay, to explore the perceptions and also misconceptions about injectable pre-exposure prophylaxis. So ethical approval, I applied for ethical approval at Texila American University Ethics Committee. So what are the expected findings? The expected findings include moderate general awareness, but also limited detailed knowledge of injectable PrEP. Then also I'm expecting to find probably willingness to use injectable PrEP, which is likely to be high once students receive adequate information with influencing factors including perceived HIV risks, accessibility, peer influence, and trust in health providers. So the study's conclusion will provide to strengthen university HIV prevention programs, guide awareness strategies, inform national PrEP implementation programs and also support Zambia's efforts towards achieving the UN goal of the 395%, which says that 95% of the people should know their HIV status. The other 95, they should be on treatment. Then the other 95, they should have their viral load suppressed. So the conclusions, the study will provide essential evidence on students' readiness for injectable PrEP. They also guide targeted awareness efforts, also improving university HIV prevention programs, because we know that in universities that's where we, young people in large numbers, and because of the high economic hardship, don't want to have boyfriends or blessers to help them with their needs, buying clothes, these expensive phones, and so on. So this study, it will really help in reducing HIV infection among young people if they have the knowledge to uptake injectable PrEP. And also the findings to increase the uptake of which are on the right, and also advance the epidemic control. So my keywords were injectable PrEP, HIV prevention, university students, knowledge, and willingness. I think this is the end of my presentation.
Any questions?
I'm here.
Mine is not a question. I think I'll be interested to see the results of this because I'm the TB HIV coordinator at Lusaka district. So we have brought down the injectable in the hospitals. So it will be good
Yes.
So it's a good question that we all been asking ourselves. But looking at the way the situation is right now, people are not abstaining. They are continuing with engaging themselves in sexual activities. So we're trying to find ways in which we can help them prevent, because even if you say stop, they're still engaging. You understand? So we want to see how best can we help them, even when they're engaging, how best can we help them to prevent them from getting HIV, and hence these strategies that have been put in place to ensure that at least they are protected. The statistics show that a lot of teenagers are actually having high numbers of HIV infections. And so we want to see how best we can prevent that using different methods like even this long-acting PrEP, because we can't stop people from doing what they want to do.
Maybe just to add on what Joker said, all of us were Christians. We can't be Christians, of course, but sex is real. So when we are looking at public health interventions, you will find certain interventions that at times are controversial depending on the Christian values. But at the end of the day, that's why the different things that we talk about. We talk about the prevention of HIV, we talk about abstinence. If you can't abstain, at least it's PrEP. If not that, it's PrEP. If not that, the lubricants. If not that, there are many other things that we can use, condoms. Not because we're promoting immorality, but at the end of the day, how to protect those that engage such kind of activities? That is our biggest burden. So apart from being a Christian, we're each other's keeper. So that is our role as public health practitioners. Thank you.
Thank you so much. I just wanted to know like the side effect, it being a new drug and it has been introduced. So I just wanted to know like the side effects and then also the effectiveness, like is it 100% or it has got some other percentage maybe which it makes it not effective like for the prevention of HIV.
Thank you. So I think Dr. is the best person to answer that question. But in terms of its efficacy or effectiveness, for a drug to be rolled out or to be given to people, it goes through certain stages. Okay? So all those stages that it goes through must be verified and checked that there are no major side effects. So if the side effects are minor, the benefits outweigh the risk, why not take it? So the drug is not just administered to people without serious routine. Yes, so there's more of the benefits than the risks. Okay, then what she asked, yes, of course, we expect some form of misbehavior when it comes to, as a result of the introduction of the drug. The time that I was doing my data collection for my PhD, like I told you, my focus was sex workers. So I'll go out in nightclubs usually to collect that. So all my people back there, a lot of questionnaires. And then yes, it was very interesting. I learned a lot interacting with these people. I learned a lot, to be honest. So I asked one, she was on PrEP. So I asked her similar question she asked. Then she told me, you see, PrEP protects against HIV infection, but most sexually transmitted diseases like STI. So I still condomize. So behind the scenes, so those that have the knowledge and they know there is the effects of sexually transmitted diseases just to protect themselves. Yeah, so we expect that behavior anyway. Anyhow, I think we end here. Thank you so much for your contribution and presence.
So there's a question for Mr. Putin from the online participants. Sorry if I missed it. But are there any plans for follow-up studies or longitudinal analysis in this area?
I think that's an eye-opener. I would love to do that because, like I said, HIV is my area, HIV prevention is my area, so I would really love to do a longitudinal study. Thank you for opening up my mind. I think that's this will be also good to do research. Thank you.
Round of applause for Mr. Now we're going to have an online presentation. Dr. Gabriel, are you ready? Hello? Doc, are you ready? Dr. Swanza, kindly unmute yourself and tell us if you're ready.
Hello. Good afternoon. Am I audible?
Good afternoon. You can share your slides if you're ready.
All right.
Okay, so
Can you see my slide?
You are sharing, I don't know what you're sharing, but can you close this one and just share your PowerPoint presentation?
Okay, just a minute. Let me try to do this.
All right.
Hello, can you see what I'm sharing right now?
We can't see your slides. Please share. There is a button, share button.
You can't see me right now?
And upload, click that share button.
Can you see?
Yes.
All right. Good afternoon, everyone. My name is Gabriel Swanza, Dr. Swanza. I'm a medical officer in charge for Senga District Hospital and a student for Masters in Public Health at Texila American University. So the title for my... Hello, am I audible?
Dr. Gabriel, please, can you maximize the screen?
Can you see my presentation?
Yeah, please maximize, enlarge the screen. Click the button right side. Besides, there is a screen. Right side.
Where exactly? I go to where it's written more.
Put in slideshow deck.
Where exactly am I supposed to go to?
Go up there. There is slideshow on top.
Right side. There is plus minus. Can you see 60%?
Go to the next one.
This one?
Slideshow. You'll be able to see.
Slide.
Just
Dr. Gabriel, please continue.
Where exactly?
Here. Far home insert
slide.
Here. No, again.
Slide notes.
Slideshow.
I can't see. I can't see where it's written that. Where is it written that? Because here there's only share, there's... Hello?
Okay, F5. F5 on your keyboard. Please press F5.
I can't get you, I can't get you. Exactly.
Please.
Hello?
Yes, please continue. Now we can able to see.
You can see it?
Yeah. Yeah, we can read your title, typhoid transmission.
All right, okay, thank you. So, can I continue?
Yeah, you can continue, please.
All right, okay, thank you so much. So the title for my presentation is Typhoid Fever Transmission Patterns and also Risk Factors in Rural Communities of Senga District, which is located in Northern Province of Zambia. So this study explores both environmental and also behavioral contributors to typhoid transmission and provide evidence to guide effective intervention. To begin with, there is a background which I'm going to talk about right now, which is also in the same abstract. So the background for this presentation is this. Typhoid fever remains a major public health challenge in many low-resource settings, and it is primarily caused by Salmonella typhi, and it is transmitted through contaminated food and water, which is also which has been happening here in Northern Province, in the district which is called Senga District Hospital. And this is the main challenge which has been also targeting a lot of people here in Senga District, because most of them, they usually have the boreholes, and the water from Chambeshi is limited. It's not that much because they usually, it is just connected to Mbara. Then from Mbara to Senga, the distance is something, it's long, it's not nearby. So most of them, they just fetch water from the streams and also from the wells. And there are few boreholes which were constructed by, but they are not clean at all. Water which is fetched from there is not clean at all. It is usually dirty, so to say. It's not conducive. So to continue, in a rural district like Senga Hill, there is inadequate sanitation, and also unsafe water supplies create ideal conditions for repeated outbreak, just like what I was explaining about, which has been happening here in Senga District, especially in terms of where to fetch the water from. And most of the sources of water here, they are not good at all. They've got some Salmonella type. So understanding this factor is crucial for the targeted interventions.
Just come, I don't know where you pressed.
Am I audible?
Yes, you are.
Hello?
Yes, you are audible.
You are audible, Doc.
All right,
Yes.
Thank you so much. So I now move on to the problem statement, which brings us to the problem we can focus on here in Senga District, which is part of Northern Province. So we see that Senga Hill District has been experiencing recurring typhoid cases over the years. And despite efforts, many communities still depend on unsafe water sources, and hygiene practices remain limited. To address this, we needed a deeper understanding of the transmission drivers within the community, which formed the basis of the study which I came up with. So concerning the same problem statement here, it's just like it's also talking about the same problem, which is the typhoid fever and how that has come to happen. And we see that the main cause of this is because of also having limited sources of water, just like what I explained, that there are a lot of streams, of course, and also there are a lot of wells which have been, which were made by people who stays here, because it's very difficult to source for the clean water. And we see that most of them, they usually use boreholes, and and water which they fetch, which they collect from those boreholes is not conducive at all, because it has some bacteria, which has led to them ending up with the same sickness of typhoid fever. And the boreholes which are here, they are not covered, most of them. And when there is rainy season, like this period of time which we are in, you find that the same dead water will be going straight into those wells which are not covered. And this has also contributed to the same problem of having typhoid fever. To continue with the same slide here, we see that to address this, I needed a deeper understanding of the transmission drivers within the community, which I'm talking about, which has been found out. So the objectives for this study, so there are three objectives, of course, as you can see on the same slide. So the first one was to investigate the patterns of typhoid transmission in Senga Hill district, which is part of Northern Province. And the second one is to identify the key environmental and behavioral risk factors which has contributed to this problem of having typhoid fever in Northern Province, in Senga district here. And also the third one is to assess the community level determinants contributing to the spread of typhoid fever. So these objectives, we see that they guided my study design and also analysis. Now we together. So I move on to the methodology. All right, thank you so much. Move on to the methodology here. So you see that I conducted a cross-section study using a mixed method approach with my team, and a total of 640 households from 20 villages were sampled using a multi-stage cluster sampling technique. And collected the data from several sources, which is typhoid cases registers, structured the questionnaires, and also the key informative interviews. So this combination allowed me and also my team to capture both the statistical and contextual insights. Move on to the data analysis. So you see that I analyzed the quantitative data using SPSS, a version of 27 with my team. And the statistical test included the chi-square and also Poisson regression and multivariable logistic regression to identify the significant associations. And for the quantitative data, thematic analysis was used to extract the themes around community perceptions and behaviors. This mixed approach improved the reliability and depth of the findings from the same community where I went to find out about all these things concerning the same spread of typhoid fever in Senga district. So the key findings, which I'll talk about water and hygiene. So one of the major findings was that 62% of households depends on untreated water sources. When I talk about untreated water sources, I mean the streams. Here in Senga district, there are a lot of streams, many of them actually, but most of them, they are not clean at all. I'll talk about one stream which is called Chela stream. And you find that in the same stream, that's where people wash clothes from. And not only that, but they also clean their motor vehicles. It's just nearby. And some people, they also go there and fetch water, which they use in their homes for cooking, drinking, and also washing some fruits. And you find that in that case, it's very simple and straightforward for them, and it's very easy for them to have the same problem or to be contacted with to contract the same typhoid fever. And we see that in addition, 148% practice consistent hand washing with the soap, because most of them are not educated about the importance of washing hands with the soap. So at the end, you find that if they want to eat something, especially fruits, they just grab them and start eating fruits like that without washing their hands, which has also contributed to the spread of typhoid fever. And also poor sanitation was highly prevalent. So these environmental and hygiene-related factors significantly contributed to the ongoing transmission of typhoid fever. The key findings, which I'll talk about risk factors which were identified as the specific high-risk behaviors. So from the analysis, so typhoid prevalence showed significant association with unsafe water sources, especially those sources which are contaminated with fecal matters, which has Salmonella type. And also poor sanitation facilities. There are some houses especially, and also some facilities which were not found in good condition. And if it's about the same houses, you find that there is poor hygiene, and also toilets are not conducive at all. And in terms of where they keep food and also water, the same containers are dirty and they don't even cover them. And most of them, you find that they even leave some cups there for collecting water if they want to use that water. And that one also contributed to the same problem. Not only that, but also consumption of the street vended food. Here in Senga, there is a special market, so to say, where most people buy food. We find that they also buy some chips there, some chickens, which maybe were cooked yesterday, and then today they start selling, they are buying. And especially those who are traveling, maybe they are coming from Kasama, going to Mbala, they are hungry, then they decide to buy food from the same market, which are not even which were not kept well, which are not hot, and which are not well prepared. And so in that way, you find that most of them, they also end up having the same problem of having typhoid fever, because they usually consume the street vended food, which is not clean at all. And furthermore, limited community health education has also led to the continued transmission within the households. So in this case, according to the findings, according to what I observed, and also the findings, is that there is also, in terms of education, a lot of people in Senga, they are not educated more about how they should keep themselves and how they should be. They should maintain cleanness in their houses, and also how to handle some food. And also most of them, you find that they don't have latrine pits, and they usually defecate in the bush. And when there is rain season, you find that all those fecal matters will be washed away into the water sources, especially the streams where they draw water from. So we need to educate more people here in Senga district about all these things.
You have taken more than 10 minutes. Hello?
All right, let me be fast. The interpretation results. So here the results show a clear pattern. Environmental condition and daily practices strongly influence the infection risk. I'm about. Hello?
Hello? Yes, Dr. Gabriel. So we're just going to give you 2 more minutes because you've gone beyond your time.
All right, thank you so much for that. I'm about to finish right now. Okay, let me continue where I ended from. So improving water and sanitation infrastructure alone is not enough. So here we also need the behavior change. in order for the community and to improve all these things which is happening here, especially concerning the same typhoid. We need to teach people about all these things, not only to improve their infrastructure. Therefore, a combined effort involving community education and intersectoral collaboration is needed, just like what I'm talking about. In conclusion, we see that typhoid transmission in Senga is driven by a combination of environmental and behavioral factors, such as access to safe water, improved sanitation, and also consistent hygiene practices are central to reducing cases. Community engagement and education should be prioritized, it should come first. It's very important to make sure that we engage these things and we also educate the community about how they should be, what they should know about cleanliness, and also how to take care of themselves in order to avoid the typhoid fever. So my recommendation are as follows. One, the strengthening water sanitation infrastructure. The second one, conducting regular hygiene and health education campaign. The third one, improving food safety and monitoring, particularly around street vended food. The fourth one, strengthening surveillance and community reporting mechanism. This action can significantly reduce the future typhoid outbreak. Acknowledgement. Finally, I would like to express my sincere appreciation to Texila American University, my supervisor, Ms. Vivian Nambure, Siamrea, and also Senga District Health Office, the community leaders, and all studies participants. Thank you so much for your attention.
So we're just going to take one question from the examiners. I hope you will get the question. And please be brief as you answer.
Hello? Can you hear me? Yes, I can hear you, although it's breaking.
Oh, thank you so much. You have specified that this problem is actually recurrent in the district of Senga. So, do you have any statistical data that shows that there's an increase or decrease or anything? Because from your presentation, you can't see any statistical data to show that actually there is this problem. And you have given us a number of reasons why you think the problem has continued to actually be there in Senga Hills. But you are talking about using you trying to analyze the trend analysis without any statistical data. It's very difficult for us to understand the association between the variables of given us to the real problem. So we don't know what you're trying to explain. That is just explanatory. So from the presentation, from my end, I feel it's just the knowledge that is being applied because there's no data. And then also, being a recurrent problem in our districts, when used to be noticed like lack of community health education, I think in research, it is important for you to use technologies very correctly. Lack and inadequate don't mean the same thing. So when you say lack, it means there's nothing happening. Is that the true picture or what you're trying to actually tell us? So we want to find out what you're trying to communicate, Doc. Thank you.
Hello, am I audible?
Yes, you can go ahead and answer.
Okay, although the network is poor, I don't know what is happening that side because I couldn't hear properly. I just heard something like, why is it the recurrent? The situation is, the situation keeps on repeating itself just like that. I don't know if you talked about that, if that is also in the question, which I can also answer, and also about the figures. So to start with, according to what I know and what I found out, is that a lot of surveillance here didn't pay attention to the same problem which the district has been having, because it keeps on going and coming back. And most of them, they just usually go to the same place where there is an outbreak, and then they provide with medications such as ceftriaxone, cefotaxime, and also azithromycin, and also some fluids, ringers that are normal saline without paying attention to what could be the cause and what they should do. Hello? And what they should do. So that was a gap according to my finding. It was a gap because what's important is first of all to get the figures or to compare the years in which people, like just to compare when the same outbreak started, which year, and how people have been managed starting from that period when. Hello?
Thank you so much. I have a few questions for you. Hello?
Okay. All right.
Yes.
Hello?
Hello. When you're presenting, you kept on saying you and your team.
Yes.
How many people do the research?
Hello? Me and my team?
You kept on saying you and your team.
Yes.
How many are you? This is not your research. You're quite a number of people.
Hello?
So is the research work according to my
It's
observation?
raining here, so network sometimes is tripping.
Oh, okay. And some questions for you, but if you're not able to get me many.
Oh, yo.
I don't know, maybe we need to pass. Oh, okay.
So what I noticed from the research, right? The results. That's the demographic characteristic of the study participants. Yes, then it talks of a cashback. It is any relationship with regards to what is finding better. It's nothing like that. So also you mentioned semantic analysis. There's nothing really, like just getting way that's saying the finding where how did you arrive at what without any statistic figure. So
hello.
Just lecture. Yes.
Hello.
And there's some 650. I don't know how you arrived at that. Yeah. So there are a lot of gaps.
Hello, I'm here. Am I audible?
Yes, sir.
Yes, I'm here. So I want to answer that question. You talked about 640 people and with my team. I want to talk about how we came up with that number, because here there are a lot of people we visited and we kept on moving door to door to find out what has been happening. Remember, in my research proposal, I had a team which I moved around, especially the surveillance and also other participants, such as the EHT and also myself. So we kept on moving and also to target those.
Thank you so much, Dr. Smile. Okay, a round of applause for him. Announcing now, we'll be breaking off for lunch, LT5, and then we'll be back at 2 p.m. So we may proceed as before. To our online participants, kindly note that we resume.
Hello, sorry, network here is bad. It's raining, so creepy. Any question?
Let them take to lunch.
The idea with MBA students, most of the MBA I see that teachers don't want just put up some name there. So it's just like you have to like this. The second thing you understand is
Can I present?
Oui. Yes. Yes. Oh, okay. I agree that. Good stuff.
Sorry? I would ask you to go down my notes.
Can I present?
But I think there's need to sit down. They're just teaching my mind supposed to be. But I don't think they're not somehow learning us by the lot of time. It's normal. She's not supposed to be saying that. Also. No, that's with my very see, but that's the way. I think my skills are very difficult. Just sitting down without coming into the which already out. Probably gonna also what my time to explain. I usually think better than that. It's not in the other ones. So, you know, then I keep your body and send messages with that. Just have it on the side of the I said.
Hello. Are you there, Mr. Secretary? Please unmute your mic. Hello.
Hello, are you able to get me?
Yeah.
Hello,
Now we can hear. Please, control.
Hello.
On your keyboard. Please put in full screen mode. Yeah.
Like
Please
that?
click it. Yes. Yeah. Please start.
Okay, good afternoon, everyone. My name is Ngandu. Presenting to you a research titled Evaluation of Antibiotic Use using a point prevalence survey at Chipata First Level Hospital in Lusaka. Those are my details and my colleague. So to start, antibiotic use is a major driver of antimicrobial resistance. And when you talk about antimicrobial resistance, we're talking about a situation where the drug is no longer able to work for a particular disease because of its misuse. Now, antimicrobial resistance causes over 1.27 million deaths annually worldwide, and threatens the effectiveness of common antibiotics. Now, it is estimated that by Murray et al., a study that was done in 2024, by 2050, we are expected to have around 10 million deaths per year if no action is taken. And Zambia lacks sufficient data on antimicrobial use at primary healthcare hospitals where most patients receive care. This study aims to fill the gap at Chipata First Level Hospital using World Health Organization's point prevalence survey method to inform antibiotic stewardship and policy. Now, the problem statement is that AMR remains a major global health threat that is driven by antibiotic misuse. And some of the studies that have been done in Africa, to be specific, in Tanzania, around 47% of antibiotic use was found. In Kenya, 67.7%, and in Nigeria, 80.6%. This is coupled with poor adherence to treatment guidelines. Now, in Zambia, antibiotic use remains high with a prevalence of around 59%, yet compliance with treatment guidelines is also low, around 27%. This study was done by Kalungia and friends. Now, the lack of data on antibiotic use in Zambia's primary healthcare hospitals underscores the very need for us to do a survey to inform and strengthen antimicrobial stewardship programs and also ultimately help reduce AMR. I think the previous week, was it the other day, we had the World AMR Week celebration. And these are some of the research objectives. The general objective was to evaluate antibiotic use at Chipata First Level Hospital in Lusaka. And the specific objectives was to assess the prevalence of antibiotic use among patients at Chipata Level 1 Hospital. And the second objective was to determine the commonly used antibiotics among patients at Chipata Level 1 Hospital in Lusaka, Zambia. And also the third was to determine the common diseases associated with antibiotic use among patients.
he disappeared. Okay. Oh, himself from his side. I don't know. No. His life is going on. From his side, he disappeared. Okay, we'll call another person. Start out.
Network interruption. Can I continue? Can I continue? Can I continue?
Signal.
Can I continue? Hello?
You lost your connection. Can you start again? Can you start from
Okay.
the methodology?
Okay.
From the methodology.
Methodology. Okay. Here. Okay. So the methodology of the study, we relied on descriptive cross-sectional study using the World Health Organization PPS methodology at Sparta First Level Hospital. Now, this study involves that we included all inpatients admitted before 08 hours on the survey day, and the sampling was purposive sampling. That was, we enrolled all eligible patients as per guidance. So the PPS guides that all patients that on that day, before 8 hours, you enroll them on the study. And mostly is for hospitals that have less than 500 beds, and which Sparta level 1 has less than 500 beds. Data collection was a retrospective review of medical records using the point prevalence survey forms that captured patient.
Okay, so now we are going to allow Lukundo. Lukundo, kindly share your presentation. Lukundo, you can share your slides. Lukundo, can you hear me? Hello? Lukundo? Yes, Rachel, you can prepare, you can go after Lukundo. But if Lukundo is not ready, Lukundo, can you unmute yourself and speak?
Unmute, please unmute.
Okay, Rachel, if you can hear us, try to unmute and share your slides, since Lukundo is not responding. Rachel, stand up.
Hello? Can you
Okay,
hear me
yes.
now? Okay, so
Yes.
can you see the screen?
No, you haven't shared it.
Uh-oh. It's telling me that I'm sharing right now. Okay, can you now see the screen?
Yes, we can see, but
Okay.
yeah.
Pardon?
Open your presentation. Open your presentation.
It's open from my end.
Network is very bad where I am. I'm so sorry.
No, can you stop sharing your slides?
Okay.
Who, me? Lukundo?
No, Mr. Signal can do. Kindly stop sharing your presentation.
Hello?
Yes, hello. Mr. Kandu, you
Hello?
can stop sharing.
Hello?
Okay, can you hear me so that I proceed?
Just a minute, Lukundo.
Okay.
Okay. Try to share your slides again, Lukundo.
I've actually shared. It's telling me that I've shared this end.
Okay, Lukundo, can you stop sharing and then reshare?
Okay. Let me reshare.
So Lukundo, open your PowerPoint presentation.
Yes, I'm trying to, but then I don't know why it's failing. It's opening from this end. I don't know why you can't see it from there.
No, full screen, madam.
No, full screen.
Just double click.
Double click.
Yeah.
Yes.
Fine.
Now it's coming?
Just a minute.
It's from our side. From her side, right? She is also on our side. Because we are seeing the complete.
Okay, so we are just seeing the screen of your computer.
Close the documents again. And
Yes,
open.
close the documents. Only open your PowerPoint presentation.
I do what?
Close the documents. The other windows.
Okay, the one which is open. Okay.
Yeah, just open your PowerPoint.
And then I share.
Yes.
Hello?
Yes, we're here. We're waiting to see your presentation. Okay.
Are you able to share from that end? I don't know why it's refusing. It's telling me I'm screen sharing right now, but I'm surprised you can't see it.
Can you click on PowerPoint? Click on PowerPoint.
Are you able to share on my behalf?
No, we can't. Share. Click on PowerPoint. Click on PowerPoint.
Yes. Okay. Can you see it now?
Is your PowerPoint open?
Yes, I've opened.
Have you shared your PowerPoint?
I'm trying to share from PowerPoint.
Share the screen. Not from PowerPoint.
Kindly speak up.
Share your screen, Lukundo. Okay, just hold on.
So I've stopped sharing. Should I reshare? And there's so much echo there. I can't hear you clearly.
Okay, share your screen and then go to PowerPoint and open your PowerPoint.
Okay. So I've opened PowerPoint now.
Share your screen now.
Can you see it now?
Just hold on. Just hold on, Lukundo. Hold on 1 minute. Okay, Lukundo, can you start
Are
your
you able to
presentation
see
now?
it? Please, I need some
Yes, we can see it.
response.
Can you start presenting now?
This is awesome.
It's us, so we're sharing.
Follow that. Follow what that is.
So the Kundo will share it for you from here. So you can present and the slides are going to be moved from here. Can you see your slides? No, I'm asking.
From that side, she can.
Yes.
I need feedback.
Can you see your slides? We have projected your slides for you.
No,
I
stop
can't
sharing.
hear
We are
you,
sharing.
unfortunately.
Hello?
Hello?
Yes.
Yes, we're saying stop sharing.
The sound is
We have
very
shared
bad.
for you.
I can hear that people are talking, but I can't hear anything really. I don't know.
Hello? Can you hear me?
Okay, can you see the screen, people?
Yes, yes. Yes, we can see.
Okay, and I'm kindly asking if you can speak a little louder because I can't hear you clearly.
Hello?
Okay, am I on the first screen, the first slide?
Yes.
Okay, so my name is Lukundo Nalwamba.
Your slideshow, put your
Pardon?
presentation
In slideshow? Okay, is that fine?
Yes.
Yes.
Okay. Thank you. So I was saying that my name is Lukundo Nalwamba. I'm a public health PhD candidate, and I'm here to share the abstract for my doctoral research project that I want to research on. And it's titled to explore the lived experiences of rural poor households of Mufulira district in Zambia regarding effects of out-of-pocket health expenditure on their well-being. So a brief background to that research project is that out-of-pocket spending are expenditures that are borne directly by a patient where neither public nor private insurance cover the full cost of the health good or service that they are seeking. And the Zambian government, as we all may be aware, signed into law the National Health Insurance Act number 2 of 2018, which legalized the establishment of the National Health Insurance Scheme under the National Health Insurance Management Authority, which is NIMA, whose objectives include protecting families from the financial hardship of huge medical bills. Now, despite this stride, you find that the majority of people in Mufulira are poor, and they rely on out-of-pocket payments for accessing healthcare, for accessing their healthcare. So national poverty level in 2022 was at 60%, with 64% of the population living below $2 per day. And the Copper Belt poverty was measured to be at 35.9%, where in Mufulira falls. So literature, the other literature that has been reviewed has showed that though vital, health service access is still denied to many poor people due to severely underfunded health systems, which force people to pay user fees, which user fees have again been abolished, but you find that under the table fees are being paid. For instance, maybe somebody goes to get a treatment and then they are told that there's no medication that has been prescribed. So people are being made to pay to go and buy medication or to pay for certain procedures that they are seeking. Some people go to extents of borrowing money or selling household items, even livestock, or asking their friends and relatives to help them whenever they are met with a health need. Some people go as far as even getting loans to pay for health care, which leads people, vulnerable groups, which are already vulnerable, this is poor households, into further poverty. And so the objectives for this study is we want to explore how poor households in rural areas access and utilize healthcare services in their communities. The second objective is how out-of-pocket payments impact poor households in a gendered way. And the third one is to establish what lived experiences or perceptions poor households in rural areas have regarding measures instituted by the government to curb the effects of out-of-pocket payments in healthcare facilities. The research gap here is that many studies, which I have not put up here due to space, have analyzed the effects of out-of-pocket payments, particularly user fees on healthcare access. Nevertheless, there is no study that has analyzed out-of-pocket payments and their effect on their well-being among the rural and poor households in the context of free primary health care and universal health coverage in Zambia. So this research gap will attempt to, this research will attempt to address this gap. What is the methodology that we are using? So this research is a qualitative research which will be utilized to meaningfully study the lived experiences of healthcare users in Mufulira. Then the research participants, I want to look at healthcare users from resource-poor households, as well as interview health facility administrators, community health workers from health facilities, as well as policy managers from line ministries, being the Ministry of Health and the Ministry of Community Development and Social Services. Then the sampling procedure, I will use purposive sampling technique in order to select information-rich participants based on their experience with out-of-pocket payments at healthcare facilities in Mufulira. The sample size, I'm looking at having maybe 45 participants, which will include 35 households from resource-poor communities in Mufulira district on the Copper Belt province of Zambia, 5 healthcare facility administrators, 2 Ministry of Community Development and Social Services officials, and 3 managers from the Provincial Health Office, the Directorates of Health Policy and Finance at Ministry of Health headquarters. Data collection, I intend to use the interview method, a semi-structured interview design. Also, focus group discussions will be used because the study seeks in-depth perceptions and lived experiences of healthcare users. I will also do observations, and secondary data will also be used for triangulation purposes. For analysis, qualitative content analysis will be used to analyze the data, meaning to extract meaning from the data that will be collected. And then study limitations. Of course, we are looking at poor people who are vulnerable in a way. So sometimes you find that they may not be able to give a true version of their experience at health facilities. So that can be a limitation on the study. Then accessibility to or willingness of participants to participate in the study. It's just being an academic exercise where there will be no financial material incentives. So this might impact the study negatively. The ethical considerations will also be upheld. I intend to seek approval from Tau Break, that is the Texila American University Research Ethics Committee. And then I will ensure that anonymity, confidentiality, and non-violation of respondents' privacy, as well as informed consent for participants will be obtained before they are interviewed. What are the results? This, as I earlier said, is a doctoral project that I intend to undertake. So I envisage that results from this doctoral study will contribute important evidence to literature on dynamic effects of healthcare expenditure on the well-being of poor households in rural communities, and that this research will have direct transferable policy relevance in the provision of fair, equitable, and timely accesses to health and to health resources. I also hope that the economic deprivation and poverty that ensue from out-of-pocket expenditures for healthcare will somehow be elicited among the poor and possibly be eradicated by certain measures that the government will have to put into place other than NEMA. What are the keywords that I've used here? I've used out-of-pocket payments, healthcare expenditure, rural and poor households, well-being, and insurance. This is the end of the presentation. Thank you.
Thank you so much, Lukundo. We're now going to have 3 questions from the audience.
Okay.
Lukundo, good afternoon.
Hello.
Yes, Lukundo, good afternoon. How are you?
I'm all right, thank you.
Yes, the first question I have for you is Mufulira a rural district or what?
It's a peri-urban district, but I'm going to look at the people that are coming from rural areas of Mufulira.
Okay.
Yes.
So, all your respondents, I've seen you saying you're going to get responses from a few households, and then also different levels of municipal structures, the THOs, PHOs, and others. So, you're trying to analyze the impact of out-of-pocket expenditures on certain individuals. So, how do you intend to know who spends out-of-pocket money for the healthcare? How will you be able to tell?
That I didn't get the last part of the question. How will I be able to tell?
Yeah, the impact. So how do you start to say this household spend so much at a particular point of time they spend on their healthcare using out-of-pocket? How are you going to tell? Using which primary data source?
Excuse me, are you able to text the question? I can't hear you. I can hear you speaking, but I really can't get what you're saying.
Unfortunately, I can't text.
Okay, I can hear you
at the moment.
Okay, I can hear you now.
What I'm saying is you're trying to analyze the impact of out-of-pocket.
Yes.
In several households.
Yes.
So how are you going to sample the households that spend?
How I'm going to sample the households?
Households that had out-of-pocket expenditures.
Okay.
Using
So
which data source?
Okay, so I'm going to look at. I said I'll involve two line ministries: the Ministry of Health and the Ministry of Community Development and Social Services. The Ministry of Community Development and Social Services has a list of those poor households that have registered for social cash transfer, and recently they even introduced health financing for under social cash transfer. So I want to use that data from the Ministry of Community Development, and then from Ministry of Health, I also want to look at those people who are coming from such areas which will be designated as rural areas who access health services, and then I'm going to follow them up, especially if they even did not have access to NEMA. So that's what I'm going to do. That's why I said I'm going to use purposive sampling, because that helps me to pick participants that are very specific to the subject that is under study.
So meaning that basically your research is relying on secondary data, not primary data.
Secondary data just for support. Primary data because I'm going to be doing in-depth interviews with those healthcare users. And then I want to now find out what effects they've had to suffer after paying for healthcare whenever they get sick.
So now, when you look at the impact, and your research, you said is qualitative. How do you analyze the impact using qualitative data?
So it is lived experiences. I want to hear what their experiences have been with using healthcare facilities. Whenever they visit healthcare facilities, do they pay? If they pay, then what has been the effect of those out-of-pocket payments? Because they are not supposed to pay as we are transitioning towards universal health coverage. So no one is supposed to actually suffer out-of-pocket payments. So my interest is what has been, pardon?
You're looking at the impact. So I think the question should be, how many people are affected by out-of-pocket expenditures? So it's supposed to be quantitative in nature, or you mix it, qualitative and quantitative. But basically, just look at qualitative data. I don't think that is sufficient.
Okay.
I hope you get my point.
Maybe I haven't gotten you very clearly that it's supposed to be.
When you're analyzing an impact, you look at the figures, how many households are affected by out-of-pocket expenditures, not all.
Okay, yeah.
So by only analyzing using qualitative analysis, you cannot come up with that kind of analysis. Okay?
Okay. Okay.
So there's a need for you to do a mixed approach of qualitative and quantitative analysis. I hope that is clear.
Okay, no, that is very clear. I understand where you are coming from. So a mixed approach, you're saying that a mixed approach would be most appropriate for this kind of research?
Yes.
Okay. I'll take that into consideration, and thank you very much for guidance.
So the next question, Ukundo.
Yes.
You're saying that OPD measurement is financial. Are there other measures that you're trying to use to identify how patients are paying out of pocket? For example, in-kind, property, or exchange of goods and services?
Kindly repeat the question?
Your definition of out of pocket, is it financial measurement?
Mm-hmm. Yes, it's supposed to be financial as well as the exchange of goods, because I earlier mentioned that some people go to an extent of selling of household goods or even livestock, depending on what asset they have.
Okay, so I'm saying that it would be good for you to exactly define what you mean by out-of-pocket expenditure, and if it's going to be services and goods that are sold into finances, to also identify what those goods and services are.
All right. Thank you. I'll also
The second
consider that.
question,
Mm.
the second question, it's not clear to me how you intend to assess the impact of the government's introduction of NEMA. How are you going to assess how NEMA has mitigated the use of out-of-pocket expenditure?
So I said that I'm going to, in my data collection, I would also want to interview administrators from the Ministry of Health, HQ, even maybe the provinces, and at the district level, and as well as at the Ministry of Community Development and Social Services, because there is an aspect of NEMA. How have they ensured that NEMA counters that out-of-pocket effect on people? And then marrying that data that I'll get from the line ministries with the experiences that the people, healthcare users have had to experience at healthcare centers, then I'm going to draw conclusions from that.
Okay, my view is that it would be best to get that opinion of the impact of NEMA from the actual clients and patients. That's a better measure rather than getting it from the Ministry of Community Development or the Ministry of Health officials.
No.
Maybe that's what I would suggest.
All right. All right. I'm thankful also for that guidance.
Okay.
Right. Maybe mine is just an addition to the impact, how maybe the impact can be assessed in this regards. I feel it would be better, just like there has been earlier mentioned, to say we get data from the patients. Maybe we should also have 2 data samples, patients that are insured, that are under NEMA, and against those that are not insured. From there, maybe we might be able to have a conclusive result on how this is affecting the other side. And this we will know to say the insured people, the OPD has not affected them that much. And then those that are not insured, we will now be able to tell to say this is the impact that it has if they are not insured. Maybe that would also help.
All right.
Thank you. Are there
So,
any other questions? All right. Thank you so much, Lukundo.
I'm grateful too for the chance, and thank you for all the valid points that have been put forth. I really appreciate.
Good afternoon. Welcome back from lunch break. Of course, we had some presentations there. This afternoon, I'm privileged to be introducing to us the first speaker to deliver the first keynote address, this second session of the 2 of the International Conference on Health and Allied Sciences. Dr. Ashwin Singh Pariha. Dr. Ashwin Singh Pariha is a renowned radiologist currently working as assistant professor of Radiology at the Mallinckrodt Institute of Radiology, Washington University School of Medicine in St. Louis. As a physician scientist dedicated to advancing diagnostic imaging, Dr. Pariha contributes to both the clinical and academic missions of MIR, a globally recognized center for radiologic innovation and patient care. At Washington University, Dr. Pariha is actively involved in clinical radiology practice, resident and fellow education, and multidisciplinary collaborations aimed at improving imaging-based diagnosis and treatment planning. His academic efforts focus on integrating cutting-edge imaging techniques with evidence-based clinical workflows, and he is committed to fostering an environment of translational research that bridges fundamental discoveries with real-world clinical applications. Dr. Pariha's work reflects a deep commitment to excellence in diagnostic radiology mentorship and academic leadership. His contributions support the Institute's mission to advance medical imaging through research, innovation, and world-class patient care. Ladies and gentlemen, with that brief introduction, join me in welcoming Dr. Pariha to present the first keynote address. Dr. Pariha, you can go ahead.
Thanks for the kind introduction, and good morning to you all from St. Louis. It's my pleasure to be here, and I'd like to thank the Dean, Dr. Amit Singh, for the kind invitation to this conference, and I'm glad to be joining you all this fine morning. I'm going to be talking about the functional imaging for optimizing care of patients with breast cancer. And breast cancer, as we all know, it's an extremely common malignancy, predominantly affecting the women, and accounts for a significant amount of mortality and morbidity. So I'd really like to explore and sort of delve into the role of functional imaging in this space and how we're really improving care of patients with breast cancer. So the learning objectives would be to describe the role of some of the functional imaging or nuclear medicine techniques in the management of these patients with breast cancer. We'll talk about some single photon and positron imaging techniques, and I'll talk about like the differences between those modalities. And then we'll talk a little bit about the imaging sort of findings. And this is my sort of brief table of contents. We'll talk about dedicated breast imaging. We're all mostly familiar with screening mammography, for example. Screening mammography is a really common tool that's being used for screening just millions and millions of women for breast cancer annually. So that's really familiar to us. But dedicated breast imaging is a relatively less explored imaging modality, and we'll talk a little bit about that. We next move on to sentinel nodal detection, and this is in patients when you already have a histopathology confirmation of a breast cancer. How do you manage those patients? And then we'll talk a little bit about what sentinel nodes are, what are the implications of detecting sentinel nodes, and sort of the consequences of a sentinel node imaging and biopsy. Then we'll talk about the clinical indications of PET-CT in breast cancer, which will really form the crux of the presentation. And we'll see why that is really essential to the management of these patients. And then we'll talk a little bit about some miscellaneous imaging techniques. So I'll start off by dedicated breast imaging. And most of the content that I'll be discussing today is from a textbook that I co-authored, and that's on the role of nuclear medicine in breast cancer. You can kind of see the citation below. When we talk about functional imaging techniques, we typically describe them as either single photon or dual photon imaging. And ultimately, think of photon as fluxes of light, right? Whenever we are using imaging, we're basically looking at light to figure out. And just when we are seeing stuff, what we are really looking at are the light photons that are being scattered by particular objects, right? So when we're looking at something, the light reflecting from that onto our retina is projecting, is forming an image on our retina that we're able to see. Sort of on a similar fashion, when we take photographs using our camera, like our mobile phones, it runs on a similar mechanism. Here, what really happens is we're using radio tracers. that we're injecting on the patient's body. And then those radio tracers, based on their specific properties, are emitting certain photons, which our imaging systems are able to capture. Now, these radio tracers have a special ability to selectively target specific sites of the body, which really helps us optimize the imaging modality, right? So you're able to image for a particular condition that you want to look at. So with single photon imaging, you're just looking at a single photon. The resolution, and by resolution, I mean what sort of is the clarity of your picture, right? So like just think of maybe 20 years back, the camera phones that we used to have were maybe 1 or 2 megapixel camera phones, and the imaging wasn't that good, right? If you zoom on the image, they would be pretty blurred. But fast forward to today, you have like, I don't know, like maybe 48 megapixels, if not more. And then you have these latest iPhones, which capture really fine images. So that is what we're talking about, resolution. So when we compare single photon versus two photon imaging, single photon imaging has relatively lower resolution. We can't see things as clearly as dual photon, but it still has its benefits. And if for single photon imaging, we're talking about breast-specific gamma imaging and molecular breast imaging. The radio tracer we talk about is technetium sestamibi. Now, when we think of mammography, which is a relatively universal screening tool used for detection of breast cancer, we know that we like to pick up early findings of breast cancer in there, right? So we're using X-rays that traverse through the breast, and then we are trying to see if there are any foci with suspicious behavior. So basically, if you're seeing irregular calcification, you're seeing abnormal thickening of the breast parenchyma, those are the things that you look for when trying to detect breast cancer. For patients with dense breasts, where the parenchyma is more fibroglandular, it's really hard to figure out where, if that nodular density that we are seeing, if that's just part of the normal parenchyma or if that's a true lesion. So then it gets slightly tricky. And that's where the role of the functional imaging steps in, such as the breast-specific gamma imaging, because now we're utilizing specific radio tracers that can go to those breast tumors and help us visualize them. So even if the patient has a dense breast parenchyma, even if the mammography is negative, you can still pick up lesions on the breast-specific gamma imaging using these radio tracers. The second sort of modality that I was alluding to earlier is the dual photon or the positron emission imaging. Positron emission tomography, as we'll talk about, is the acronym is PET. What it really does is it utilizes a subset of tracers that, again, are releasing two photons instead of one. And by capturing those two photons simultaneously, you're able to get a much better resolution of the image. So your images are not as blurry as you get with single photon imaging, so you have more clarity. Obviously, the downsides are that the imaging modality itself is expensive. The radio tracers are expensive. Setting up the machines and costs, it can be prohibitive. So therefore, both of those modalities have their role. We talk about positron emission mammography as well as dedicated breast PET. Again, you're looking for patients who are not the normal, regular patients at risk for breast cancer. You're really targeting patients who are sort of at a higher risk with maybe dense breast parenchyma where the mammography is not conclusive. So you really want to be improving your sensitivity for picking up lesions there. And I'm showing some images here for the modalities that I was telling you about. These are the single photon imaging instruments. And again, you can kind of see, if you see, let me put on the laser pointer. So if you see this is sort of a ring-like system where you have, at the end, you have these two positioning devices, and this is capturing the photons that are being released from the patient's site of interest. And there are some other sort of similar imaging tools. Dual photon or positron imaging, again, we have several different machines available that can look at the breast specifically. So your resolution for imaging of breast lesions becomes really high. Moving on to sentinel nodal detection, I'd like to start off by briefly mentioning what a sentinel node is. The word sentinel itself comes from the ancient Roman guards. So if you see movies, the old Greek and Roman movies, you'll see that the big castles are usually protected at the sort of the first margin by usually like two guards. There's like a big wall there. Those are typically known as sentinel guards. The reason they're referred to as sentinels is because if an army is invading sort of that fort, they are usually the first point of contact, right? So if they are invaded, the likelihood of the castle getting invaded is highly likely. So they're usually the first point of contact at preventing sort of enemy from entering the fort, and they're also responsible for maintaining the integrity of the indoors. So that's where the sentinel node word comes from. But what it really means in medical sciences, not just in imaging, is this is the first lymph node that's on the direct draining pathway from a tumor. So if you have a tumor in the breast, we know that like our body has that lymphatic system, which is pretty much well organized. A particular part of the body drains in a specific way, right? So if you have your arm, you usually have drainage to the axillary nodes. Your head and neck drains to the cervical lymph nodes. So there is a clear-cut pathway for that. But tumors, because of their inherent nature, they don't typically follow that standard drainage pathway. So they have what's called as aberrant lymphatic channels, which means that they'll spread along those in a relatively disproportionate manner. So in this sense, sentinel node refers to the first node that's on the direct draining pathway from the tumor. What that means is if the tumor is metastasizing or is spreading throughout the body through a lymphatic pathway, that is going to be the first point of contact, which really means that if you can identify that node, you can take it out, then what you can do with that is if you check if it's involved with metastatic disease or not, that'll help you determine the likelihood of the distant spread of the disease. So if that lymph node is already involved with metastatic disease, the likelihood of the patient having metastatic disease at further nodes is high. If that lymph node does not have metastatic disease, again, the likelihood of spread beyond that node is low. So that's the importance of sentinel node detection. And here I'm showing some imaging. The way we do it is we inject the radio tracer several sites around the primary lesion in the breast. So this sort of intense star-shaped sort of white spot that you're seeing is the injected activity. And then the radio tracer will follow the pathway that the tumors are likely to follow, because that's the reason why we're injecting sort of in the same region, right? And then these sort of more fainter spots that you're seeing are the lymph nodes that are showing up because the radio tracer is gradually moving on from the site of injection to those lymph nodes. The indications of sentinel node imaging or sentinel node detection are in patients with early stage biopsy-proven breast cancer with a clinically N0 axilla. Again, you don't want to do this in patients who already have palpable lymph nodes. So for example, patient with newly diagnosed breast cancer, you palpate the axilla and you find enlarged hard nodes. The likelihood of those nodes being metastatic are pretty high. So again, there's no point doing a sentinel node imaging because you already know that there is lymph nodal metastasis. You want to do this in patients where you don't have a suspicion for a nodal disease in the axilla, and therefore you want to rule out a much significant nodal metastatic disease. Now, in a patient like this, if you're able to identify the sentinel node and on histopathology, if you can prove that it's benign, then you don't have to do an extensive axillary nodal dissection because that has its own morbidities. This is the radio tracer that we use. It's called as technetium tilmanocept. And again, it follows the pathway for the lymphatic channels. We inject it typically intradermally or subcutaneously. Again, we want to mimic the natural pathway for these tumor spread. On a case-by-case basis, we can do dynamic imaging, which means that after injection, you're waiting for a while, the patient is under the camera, and you're kind of visualizing how the tracer is moving along the lymphatic channels. That can be helpful, especially in patients with head and neck tumors, not so much in breast cancer. And then SPECT-CT is basically obtaining additional tomographic images. So by tomographic images, I mean that on this panel, what you have is essentially a two-dimensional picture, right? You're seeing the sort of the length and the width, but you don't have a perception of depth here. So to get that perception of depth, really look at images or identify the structures in 3D, you need to obtain tomographic projections. In that situation, the camera sort of moves around the patient. So you're getting the whole 360-degree view, and you can generate 3D images. If you've seen CT images, those again are tomographic images. So those can be helpful in certain patient population. Next, we'll talk about really the role of PET-CT in breast cancer. And I'd like to emphasize on this because PET-CT is really, really central to management of patients with breast cancer. Staging is sort of the first major indication for FDG PET-CT in breast cancer. And when you have a patient with newly diagnosed breast cancer, depending on what stage of the disease it is, you want to get an FDG PET. By FDG PET, you can get a whole body assessment, and you're really able to look for if the tumor is still at the primary breast or it has spread or metastasized to other organs or other lymph nodes. And that really changes management. If you have a disease that's predominantly local or even locally advanced at certain point, you can treat them with surgery, for example, with addition of neoadjuvant or adjuvant chemotherapies. But then if the patient already has metastatic disease at presentation, you don't want to unnecessarily expose them to the significant morbidities that surgery might have. And it's pretty much futile to take out the primary tumor in majority of those cases, just because the disease is already spread beyond the breast. When these patients are treated, we also get consequent imaging to assess the response that these patients are being treated with. So a lot of these times, these patients are getting chemotherapy. So every 3 to 6 months, they'll get scans just to figure out if the treatment they're getting is working for them. If not, then we can point that out, and then again, a new treatment plan can be instituted. Restaging or detection of recurrence, those are also important indications. So patients are treated, they achieve complete remission of disease, and then maybe 6 months, 1 year, 2 years later, they develop sites that are suspicious for disease recurrence. So again, PET-CT is useful in those cases. When we're looking at a PET-CT, we're really looking at how much of the radiotracer is going to the tumor sites. The most common one that we use is fluorodeoxyglucose, or FDG. So there are certain situations where this has a very high yield, and those include patients with high-grade carcinomas, invasive ductal carcinomas. Invasive ductal carcinomas, that is, again, you'll recall recently the WHO changed its nomenclature. So initially it was called as invasive ductal. Now it's being called as breast carcinoma, not otherwise specified. But regardless, that's the most common histologic type of breast carcinoma. Triple negative breast cancer is a condition where your breast cancer is aggressive. And by triple negative, we mean that it's negative for expressing the hormone receptors that normally breast cancers do. So when you think of breast cancer on histology, you'll typically see staining for ER, PR, and HER2. ER is estrogen receptor, PR is progesterone receptor, and HER2 is one of the epidermal growth factor receptors. So ER, PR positive is the most common variety, but occasionally you get patients with triple negative disease where the tumors are not expressing any of these three receptors. And those are really aggressive forms of cancer and need to be dealt with using cytotoxic chemotherapies. Luminal B type, again, versus luminal A, sort of easier to detect. And it's not super important to sort of memorize this, but it's really useful for us in the clinical setting. This is the TNM staging of breast cancer. And the red box basically tells the patients who benefit from FDG PET. So if you have a disease that's the AJCC staging is 2B or beyond, that's when FDG PET is indicated. Now you may ask, why is FDG PET not useful in the earlier stages? And again, the answer is that the likelihood of metastatic disease at earlier stages is pretty low. So the yield of FDG PET-CT is, again, not likely high in these settings. As you move from stage 2B to beyond, your likelihood of metastatic disease and extensive disease burden is pretty high. So you want to image those patients with FDG PET. And this blue box, which highlights patients with stage 3A to 3C disease, is called as locally advanced breast cancer, where the disease in the breast is quite significant and the likelihood of metastatic disease is high. So definitely you want to stage these patients with FDG PET. Another modality that we use in patients with breast cancer is fluoroestradiol PET. It's called as FES. And I mentioned just a little while before that patients with breast cancer, they're also expressing these hormone receptors. So FES PET really targets the estrogen receptors on these tumors, and you can visualize those receptors on imaging. And this is sort of the normal biodistribution. You're seeing activity, this is activity along the injected side, and this is really how the FES PET image looks like. You have normal activity within the liver and within the small bowel loops. And you also see some activity in the endometrium, because our endometrium, the uterine lining, also has physiologic expression of estrogen receptors. So I'll show a few cases and then I'll summarize. This is a 68-year-old female with invasive lobular carcinoma who presented to us with rising tumor markers. She was already on treatment with exemestane and palbociclib. We obtained an FDG PET, and that's really one of the most common PET tracers that we look at. And we really could not identify a disease site. But when you have patients with rising tumor markers, you're still suspicious that your imaging test might not be giving you the complete information. So therefore, we also got an FES PET. And FES PET, again, like I said, is more selective for targeting estrogen receptors. And you can kind of see this sort of focal spot here and another one there. And these are suspicious. And in this patient, those sites were sites of disease. Additionally, you can kind of see the normal liver activity in this patient, which is expected. Another patient who was presenting to us with breast cancer treated, you can kind of see the mastectomy and just the breast prosthesis post mastectomy. And this patient is presenting to us with several mediastinal and hilar lymph nodes that you can see on the maximum intensity projection image here. And those are concerning. You can see how the amount of radiotracer activity is much high when you compare it to sort of the background activity. But we got an FES because the patient was initially having estrogen receptor positive disease, and that was negative. Again, that lowers your likelihood that this is going to be disease. FDG is more of a non-specific radiotracer, which means that it will go wherever glucose goes. So if you have sites of infection or inflammation, those will also take up FDG, which is the plausible explanation of why those lymph nodes are sort of very avid on FDG, but not so on FES, because FES is much more selective than FDG. So the clinical indications for FES PET-CT include predicting response to treatment. So these patients are treated with endocrine therapy. And this is a systematic review we published a little while back that showed that if you have patients who have disease positive on FES, there's a high likelihood of benefit from endocrine therapy. What you're really trying to see here is that whether the patient's tumor sites are expressing the estrogen receptor or not. And if they are, then when you treat them with estrogen-targeted therapies, those patients stand to benefit a whole lot more. If you compare this 66% of 6 in 9 patients deriving clinical benefit from patients who do not have radiotracer activity, you see just 1 in 9 patients will have benefit from endocrine therapy. So therefore, imaging can really help guide therapies. Invasive lobular carcinomas and low-grade ductal carcinomas can have low-level activity on FDG, so FES will be helpful. And you can use it to characterize lesions that are difficult to biopsy or those that are where the biopsy is basically non-diagnostic. So with that, I'd like to thank all of you. I know functional imaging, its use is relatively sparse outside of major medical centers, but I feel like as we are active on more scientific advancements, these are really going to shape the management of our patients, not just with these cancers, but with other conditions as well. So with that, I'd like to thank everyone, all the attendees, all the organizers for the kind invitation. And again, I'd like to thank the Dean, Professor Amit Singh, for his kind invitation. He was my mentor back in medical school, and I still cherish our times there. So thank you, everyone. I really appreciate the opportunity.
Thank you so much. It was a very wonderful presentation from Dr. Pariham. I want to invite questions. Those that have questions, okay. Thank you so much. Okay.
Thank you so much, Dr. Singh. thank you for your presentation, a wonderful presentation that demonstrates quite clearly that there is a progress in the way that we diagnose breast cancer. My main intervention here is sort of indicate to you that in our context in Africa, a very difficult situation where these imaging and radio imaging techniques are well established, but only in centers that are urban. So you have a situation where a patient has to travel vast distances in order to access these services. And they come into unfamiliar surroundings, an urban setting where they don't sometimes have any relatives. And at the time when they do come here, maybe their cancers are very, very, advanced. And then you find that these patients also sometimes find the machines are not working because they're broken down, the spares are not there, the radio imaging are not there, and then they have to go back to their village. And by the time they come back the next time, they have, their cancers advanced state where they're inoperable. Excuse me, a sad situation, and actually a death sentence for patients. So basically, what I'm saying is that, the question I have is, this technology and the cost of this technology, what is it, and exactly can it be applied here in the context of Africa, in the context of Zambia? Because I think there is a point in the case where you can use simpler technologies that have a similar effect. And I think that I'll share my experience using simple technologies to actually assess breast.
Thank you. You brought up several very important points, and unfortunately, the world we live in is not one where there is healthcare equity. As much as we'd like for there to be healthcare equity, we're still not there. So I'll answer this in two ways, and I'm not sure I can even provide a conclusive sort of solution to your question. One, there are agencies such as the WHO and UNICEF that are promoting sort of the adoption of these molecular imaging techniques in areas where there might be low resources or again, low resources places are where you want to go because there is higher patient population in those areas which are likely to derive benefit out of such modalities. So there are initiatives really looking into improving healthcare equity in these terms. Second, the one thing that I personally know of is there are places in Africa which are really focusing on some of the refurbished equipment, and I know it's really challenging, especially when you're constrained on resources. It can be really challenging to not only support the machines, because machines are just one part of the picture. You have to have like a constant radio tracer supply. You need to maintain your logistics. You need to get maintenance, and you need to have trained physicians who are sort of capable to interpret these findings in the correct clinical context. So there are initiatives which are working on it, and again, like I said earlier during my presentation, some of the single photon imaging modalities are producing blurry images, but we still use them, right? So we always want our imaging modalities to be as simple and as rapidly adoptable as possible. So again, while we may not get the latest scientific advancement immediately, we would like for the patients to have at least the basic sort of simple technique that can help in management of those patients. And again, there are organizations that are working on it, improving the access. I know IAEA is also one of them, the International Atomic Energy board that's also working on it. So I'm really hopeful that we'll have our patients get access to these imaging modalities, because this is really changing the way we manage patients with different kind of malignancies. But I realize that we're not there yet, and we have to make strong efforts to kind of get there and work with all of our stakeholders and partners, including industry, including hospital centers, and including our physician partners.
Thank you, Dr. Singh. I just want to make one last comment and example of how we are trying to mitigate the lack of radio imaging techniques in Zambia. I recently did a study beginning of this year where I looked at the cancers, all kinds of cancers in men and women in the Comesa region. The Comesa region is 22 African countries from Zambia all the way up to Egypt, Tunisia, Comoros, Mauritius, and so on. So in these 22 countries, we find that there's a lack of adequate imaging facilities and techniques, which then results in lack of access. So in Zambia, we've actually piloted a technique that uses radio, or what I'll call thermal imaging. That's the heat signal that is transmitted by the breast when you've got a cancer. Because cancer cells are multiplying, they produce more heat, and so therefore the breast will appear more warm as you use the radio imaging device. But the innovation that we've used is that we've actually used artificial learning and artificial intelligence learning to teach the programs that we have and the algorithm to actually identify which heat signals indicate the likelihood of cancer. That's a very simple technique. And using that technique, we're able to identify very clearly, and it's learning. This is a machine learning process. As it gets better and better, as we see more and more patients, we begin to see it work better. And in this way, we're able to screen better, and then also follow up patients with, treatments using chemotherapy or radiotherapy, whatever treatment modalities. That is very cost effective, and it's available anywhere in the country. Okay, I think I've talked
Thank
enough.
you. No, I'm glad you brought it up. It's really fascinating how the relative absence of resources makes the human mind innovate. I'm glad you did that research and you shared it with me. It's really fascinating. The use of AI, I think, is really going to change the medical landscape. It's already changing the medical landscape, and it's going to continue to do so in the next years to come. I'm glad you're harnessing the power of AI and again, sort of helping bridge the inequity in healthcare. So congratulations on your research, and I wish you all the best.
Thank you so much. Do we have any last question? Just come there.
So, as we were talking, we talked about the single photon, which is a technique used to identify breast cancer gamma imaging. And gamma imaging, it means radioactive rays. So, as radioactive rays are also dangerous cause of cell damage and risk of cancer, what is the effect that it has on patients that are already cancerous, or patients that are already in the treatment?
That's a really great and very valid question that our patients ask us as well. So two things. Gamma photons are slightly different from X-rays. What really happens is in sort of the gamma emission, there is usually some form of changes in which there is the nucleus involved, and X-rays are usually the electrons that are being emitted from typically the outer shell. So although they're both on the electromagnetic radiation spectrum, they're still different. Now, what you mean by damage to normal tissues, any form of ionizing radiation can damage tissues. So that's true for our both gamma photons as well as for X-rays. Now, sort of in the broader term of things, whenever we think of radiation, and when I say radiation, I mean ionizing radiation, we always like to have a risk to benefit calculation, right? So any form of ionizing radiation can be damaging. That's long-held verbiage, although there is not sufficient evidence to support that. But even assuming that you want to expose patients or any living being to radiation only when the benefit of getting that radiation is far outweighing the risk associated with the radiation. So now, for example, I talked about patients with breast cancer, right? When you're exposing the patients to radiation, and that includes radiation therapy, for example, so when you're actually treating these patients using X-ray beams or electron beams, or giving them a small amount of radionuclide, which is emitting gamma photons. Those are both ionizing radiation. You want to make sure that the benefit of administering or exposing the tissue to radiation is much more than the risk associated. In terms of imaging, the radiation dose that the patients get is really low for single photon imaging because these are very short-lived radionuclides. Technetium-99m has a half-life of about 6 hours, which means that by a day or so, it's almost practically gone from your system. And the time it exposes your tissues to radiation, that radiation is very low level, and it's highly unlikely to cause any significant tissue damage. But again, you don't want to be doing that to someone who you think would not derive any benefit out of it. So again, if you're exposing the radiation, that's why, when I showed that slide where I talked about the TNM staging, you could get an FDG PET in all the patients with breast cancer, but why do you selectively do it in patients who at least have a stage 2B or higher disease? Because our prior research has shown that if you do it in patients who are lesser than stage 2B, which means early breast cancer, the likelihood of PET showing metastatic disease is pretty low. So in that case, you're sort of unnecessarily exposing them to radiation, right? They're not getting any significant benefit out of it. The information that you had before the imaging is still the information that you will likely have after the imaging. So why expose them to radiation if there's no significant benefit? But if the patients are having relatively advanced breast cancer, 2B or beyond, then you really have an impact, right? Because if the patients end up with metastatic disease, then you're changing your treatment plans. You may be moving from surgery to sort of more systemic chemotherapy, or you might be adding like a neoadjuvant treatment to your surgery. So that's where you're impacting management. So that's when your risk-benefit equation tilts in the favor of benefit. I hope that answers your question.
Does that answer your question? Okay. Thank you so much, Dr. Singh, for that wonderful, informative presentation, to address to this conference. We appreciate so much. I think we're going to have to move forward to the next item. And so I'm going to be inviting the next presenter, and that is Ms. Fiza Jadana, to come and give a presentation on the patterns of e-cigarette use and associated health perceptions among young adults. Ms. Fiza, please, let's put our hands together for her.
Good afternoon, everyone. Thank you for being here today. So my topic I have chosen is the patterns of e-cigarette use and associated health perceptions among the young adults in Lusaka, Zambia. So I'm sure most of you know what the traditional tobacco cigarette smoking is, but a quite new topic is e-cigarettes. So we can move on to the background of the study. E-cigarette use has increased globally, particularly among young adults, yet evidence from sub-Saharan Africa remains limited. In Zambia, little is known about the patterns of vaping and how young adults perceive its health risks. Existing research in the region focuses largely on traditional tobacco cigarette smoking, creating a significant gap in understanding knowledge, attitudes, and practices related to e-cigarettes. The study addresses the gap by exploring vaping behavior and associated health perceptions among the young adults in Lusaka, contributing to emerging evidence within the health and allied sciences. So for the objectives, the study aims to determine the patterns of e-cigarette use among young adults aged 18 to 29 years in Lusaka, and to assess their knowledge, attitudes, and practices regarding vaping. It also seeks to explore perceived health risks and the factors influencing their uptake and continued use. So the methods I have chosen to do a cross-sectional CAP study. It will be conducted among the young adults aged 18 to 29. A structured self-administered questionnaire will be used to collect data on socio-demographics, vaping behavior, knowledge on health effects, attitudes towards e-cigarette use, and related practices. The sample will be selected through a multi-stage or a convenient sampling, depending on the feasibility. Quantitative data will be analyzed using descriptive and inferential statistics, while any open-ended responses will undergo thematic analysis. So what I'm trying to say is it will be a qualitative and quantitative analysis. Ethical approval will be obtained from the appropriate institutional review board. Expected results. The study is expected to reveal varying levels of knowledge, attitudes towards vaping, and increasing experimentation or regular use among the young adults. Findings will likely highlight misconceptions about safety and identity factors such as peer influence, perceived harm, and accessibility as key drivers. For the conclusion, the results will provide essential evidence to guide health promotion, policy development, and targeted educational interventions addressing e-cigarette use in Zambia. So I would like to close with the question of, after this research gap has been filled, will government policymakers ban e-cigarettes, or will the e-cigarettes marketing and income win this battle? Thank you. Are there any questions?
Any questions from the audience?
One of the interesting questions that I think people will find is which social classes are using e-cigarettes and the cost of these e-cigarettes. And then also I've noticed that in some of the clubs, there's what's called shisha. And there's also portable shisha. It's not e-cigarettes, it's portable shisha. So what is, I mean, when you look at this, are you looking at maybe doing a further study to look at shisha in clubs and looking at portable shisha?
My external supervisor is actually Mr. Alvin Mafuzi, and we were to submit 2 topics. So my first choice was the e-cigarettes, and my second choice was the hookah shisha pipes. So I did find more research being done on the shisha pipes already. That's why I chose to do the e-cigarettes. But as you said, there are new small devices of the shisha pipes being released. So that could be another route in after my e-cigarette analysis that I could do. But there is already quite a lot of research done on shisha pipes. That's why I chose e-cigarette. Yes.
Thank you for the wonderful presentation. I just needed a clarification on the design, because remember that the design is a blueprint of a retailer. You said mixed study, but I didn't hear you say mention any designs for mixed study. Is there a design that you are planning to use for mixed studies?
So first I want to conduct a CAP study as I'm writing my thesis. And then that will be a quantitative analysis, and then the qualitative part when I am complete my thesis and the stuff I have to actually submit, I want to carry it on into with a mixed study, with a qualitative, because there's a lot of open-ended questions that can be asked to users that I'd like to know as well.
Yes, qualitative is important for in-depth because you need to get why maybe the numbers. We have numbers now, we want to voice. But I recommend that you read first well. There are about 4 main designs for sequential, exponential, concurrent embedded, and there's also parallel. There's connected parallel design. So those are the main 4. And when you go through them, they'll tell you which one you start with. Are you going to start with mixed? Are you going to start with quantitative or quality? And then there's a justification for it. So you need to choose one so that you don't just go in all directions. Those mixed studies are there all the time.
Okay,
thank you.
Thank you. Thank you so much.
Thank you. Another round of applause for this. So right about now, we are going to have another virtual presentation from
Prepare.
Good afternoon. Chica, can you share your presentation? Hello? Mtinta, are you there?
Yes, yes, madam.
Okay. Okay, you can just share your presentation. Okay, please unmute yourself, Tinta.
Okay.
Okay, now can you share your presentation?
I'm trying to share, madam. Now I think the issue of network. Is it okay if you can share from your end?
Just a minute. Okay, Rachel, if you're ready, you can share your presentation.
Okay, let me try and share the screen. Are you able to see my screen?
Okay, yes. Dr. Rachel, you can go ahead.
All right.
I'll put your presentation in slideshow. Okay, you can start.
Okay, good afternoon, everyone. Thank you for this opportunity. Thank you to Texila American University for an opportunity to do my master's in public health with you. I will go ahead and go straight into the presentation. So My research topic is effects of postpartum depression on mothers and infants. My name is Dr. Rachel Senga, currently working at Levi Mwanawasa University Teaching Hospital. And I would like to also acknowledge my supervisor, Mrs. Niza Simwanza. Thank you very much for your guidance and support. So I'll go straight into the background. What is postpartum depression? What are we looking at? So postpartum depression is a mood disorder characterized by the persistence, feeling of sadness, low energy, and emotional distress, which happens within the first year of childbirth. And this condition may interfere with a mother's daily care. I think I just lost. Are you still able to see my slides?
Yes.
Okay. Okay, so the ability to care for herself and her newborn. Some of the symptoms of postpartum depression, like I had earlier mentioned in the background, is feeling of sadness, hopelessness, and numbness, loss of interest in one's hobbies, extreme irritability and anger, difficulties bonding with the baby, and thoughts of failure. We have another picture this side, which shows us some of the symptoms, which is sadness, trouble bonding with a baby, and one going to the extremes of having self-harm. Our next slide is just going to go further into talking about the factors that can lead to postpartum depression. So we have different factors, social and demographic factors, which include age, marital status, educational level, socioeconomic status. We have obstetric and medical factors, pregnancy complications, the mode of delivery. So these are some of the factors that will lead to postpartum depression. I'll talk a little bit more on mode of delivery. When somebody has a traumatic birth experience, this usually is a high risk for someone developing postpartum depression. Or when they have a complicated pregnancy, maybe they have PPH, which is postpartum hemorrhage. A patient bleeds a lot. This also tends to affect them after the delivery. Psychosocial factors also, lack of social support, marital conflicts when you have a partner that's not supportive of your pregnancy journey, and everything that comes with pregnancy, it also tends to affect somebody's mental health. Stressful life events, and also cultural expectations. Culturally, it is believed that every mother should be happy after they deliver, and you are also expected to perform in a certain way after delivery. But if you don't perform in as the society expects you to perform, there's some form of stigma, or you are considered to be not woman enough or mother enough. And some of these factors, when a mother goes through postpartum depression, it directly affects the infants. So how the mother is going to care for their child is going to be affected. So we'll also get to experience infant health complications, infant temperaments, and feeding difficulties as a result of having postpartum depression. So my research is going to be conducted at Levi Mwanawasa University Teaching Hospital. So Levi receives mothers from diverse socioeconomic backgrounds. So we're looking at people coming from poor backgrounds, good backgrounds, wealthy people, all attend antenatal clinics at Levi and postnatal clinics at Levi. So postpartum depression negatively affects the infant's growth, breastfeeding, bonding, and development. And as of today, there's still very limited data on postpartum depression, which is needed to help guide interventions or set up policies. So the aim of my study is to assess the effects of postpartum depression on the mothers and their infants that attend postnatal care at Lilayi Campus University Teaching Hospital in Lusaka, Zambia, and to also determine the prevalence of postpartum depression at Lilayi. The methodology, I'm going to use a descriptive cross-sectional study, a sample size of 50 postpartum mothers. I thought this is going to be a good number to start with, and also it will encompass everyone. We're going to use the systemic random sampling. So any patient who comes into the clinic for postnatal care is going to be assessed. Anyone who we feel is exhibiting some mental health challenges is going to be assessed. And then after we reach our target of 50, we will use the analysis. Sorry, I think I just missed out on putting data analysis. I'll be using the SPSS to analyze the data. And then the tool that I'm going to be using for this assessment is the Edinburgh Postpartum Depression Scale. So this has about 10 questions that will be given to the participants. So they'll be able to answer. For those that are unable to read, we're going to have an interpreter who's going to be able to interpret what is written in the scale and for them to answer. And like I had earlier mentioned, the setting is going to be at Lilayi University Teaching Hospital Postnatal Clinic. Yes, so data collection analysis, we have a structured questionnaire which will be administered, and also the infant indicators that will be used to assess the effects of postpartum depression will be the weight gain of the infants, the feeding patterns, the immunization adherence. So everyone who comes for postnatal care has to come with their under 5 card, so that we also check that to see if they are adherent to the immunization schedule for the infant. Like earlier stated, we'll be using the SPSS to analyze the data, and results will be presented in tables and figures. Ethical approval will be done from the Texila Research Executive Committee and also from the Lilayi University Teaching Hospital Management. Expected results, we expect to have a significant prevalence of depressive symptoms, and also possible association with poor mother and infant bonding, reduced breastfeeding frequency, delayed infant developmental responses, and this will also help us to highlight the need for early screening. So in conclusion, postpartum depression affects both mothers and infants. Early detection can improve mental health outcomes. This study will contribute to the local evidence, and also findings will support the targeted intervention programs, promoting healthier mothers, stronger infants, and stronger infant development. My recommendations would be to have routine postpartum depression screening in all the postnatal care clinics, not only at Lilayi, but this will be a start. To have mental health support, which should be strengthened in maternal services. Early identification can prevent negative maternal and infant outcome. And the evidence can also help to put in policies and resource allocations. Thank you very much.
Thank you so much, Dr. Singa.
Okay, do we have any questions from the audience? questions on this presentation?
Texila, are you able to get me?
Yes, I can get you.
Thank you so much. You alluded to say that you want to assess the impact of postpartum depression on mothers and children. So, who are target respondents in this research?
The postnatal mothers, so anyone who has delivered between first week up to 1 year postpartum.
Is it possible for a mother who has been going through depression to analyze critically what they went through?
Sorry, come again?
Is it possible for a mother who was undergoing depression to understand the environment in which she was at the time that she had the depression? Can she give you a straight and precise situation analysis of what she went through and what really happened?
I can't clearly get your question.
You are saying you're going to get your data from the patients or the mothers
Yes.
who underwent a postpartum depression in the first 1 year, not so?
Yes, yes.
Thank you. So what I'm asking is, when you're asking these patients, are they able to give you a precise picture or scenario of what they went through during that period and the effects that they actually faced, including that of their own baby?
I believe so. If we're using the Edinburgh scale, it has questions that ask how the mother has been faring in the past 7 days. So looking at those questions, I'm sure they'll be able to pick on how they have been faring throughout and give us a positive response. Or if we're looking at mothers that are unable to give us a response, if they are still undergoing the depression, we'll also set up possible referral centers where if they are not able to give us the information that it is needed, then we can refer them to the nearest psychiatric hospital.
Thank you. All right, thank you so much, Dr. Singer. Okay, good afternoon once more, maybe for the last time. All right, so right about now, I'm again privileged to be introducing to us the last but not the least keynote speaker to give the final keynote address at the 3rd International Conference on Health and Allied Sciences, Dr. Lilayi Campus. I'm going to give a brief biography. So Dr. Lilayi Campus is a research scholar at Harvard T.H. Chan School of Public Health, where she is engaged in advanced research at the intersection of public health, science, data-driven policy, and global health. Her work focuses on developing evidence-based strategies to address critical public health challenges, emphasizing epidemiology, health system strengthening, and population health analysis. At Harvard, Dr. Pant collaborates with interdisciplinary teams to design, implement, and evaluate research initiatives that inform public health practice and policy. Her scholarly contributions reflect a strong commitment to improving health equity, advancing methodological rigor, and translating research findings into actionable interventions that benefit diverse populations globally. with a background rooted in scientific inquiry and a passion for meaningful public health impact, Dr. Pant continues to contribute to the field through academic research, mentorship, and international collaboration. Her work aligns with Harvard's mission to advance public health through innovation, education, and global engagement. Okay, so that was the brief introduction. I think with that brief introduction, join me with a round of applause in bringing to the podium Dr. Lilayi Campus, Lilayi Campus.
Thank you so much for that wonderful and amazing introduction. I will be presenting one of my practicum topic that I'm working on. It's related to the rising incidence of breast cancer among young females. So I might have to test your patience because I'm still figuring out how to share my screen with all of you so that you can see my presentation. If you could allow me just a few minutes to figure this out. Okay.
Madam, there is a share option. Open your
Yeah,
screen.
I know. I actually am trying to open my screen first, the screen that I want to share. I will just do it. Yeah.
Yes, madam. We can able to see. Just can you enlarge?
Okay. Okay. So yeah, so this is one of the course that I'm doing at Harvard. We have to work on a practicum topic, and this is not exactly my practicum topic, but definitely an area which I'm interested in. I want to say that these slides, the content is mine, but the slides have been modified using an app. So now let's talk about the breast cancer in young females or young adults. We know that the cancer has been rising lately in young adults, and it's a globally increasing area where everybody is concerned because if you see the current status, they're often getting especially if we talk about breast cancer in young females, they are often diagnosed later because current recommendation is to screen after 40 years, and even before that it was after 45 years, and from 45 it has come down to 40, but still women are often getting diagnosed below 40 years, even though it is not a very common occurrence. The breast cancer is not commonly occurring in age group less than 40 years, but if we see the trend, it is definitely increasing. There is disparities. Now I am talking about the US data. There is disparities in geographical and outcome gaps, and even in globally it has been seen that different areas have different mortality and incidence rate for cancer, especially mortality, because if the cancer in the young females is mostly dependent on what kind of treatment you are giving them, because as we know that they do not fall under the category of the screening. So the main outcome for them is totally dependent upon what kind of treatment they're getting, how quickly they are getting diagnosed, so all those things. Now obviously when we talk about young females, they have unique biological and social needs. We need to fit some kind of special interventions for them because they are the women who fall into the reproductive age group. They have families, they have children, parenthood, motherhood. They are doing jobs, their career. It's a very important life time in their period, and there's loss of productivity because of diagnosis of breast cancer. So that is the reason why I got interested in this topic. Now this is the slide that I have taken from CDC. They have shown the trends in the breast cancer for the past 20 years, and we clearly see the trend has been rising. And again, even the trend is rising, plus there is disparity as well among the different ethnic groups. So it's like a double burden situation for us, that the trend is not uniform and uniformly rising for all the groups. So that again adds another layer
Sorry for interrupting. Slides are not moving. The slides are not moving, please.
Is it moving now?
Still at the title slide only. Can you move
okay.
from your side? Yeah.
From my side, it is actually moved. Can you see the first slide, the current status, trend, disparities?
Yeah, we can see the first slide, and it is not in full mode, not in presentation mode. Yeah. Now, can you restart again? I mean, reshare the PPT again.
Yeah. Can you see the next slide now?
Yes, ma'am.
Okay. So I think I've already talked about this slide, that why I was interested in this topic and why we need to discuss this in current scenario. And then can you see the graph where I'm showing the graph from the CDC, which is showing the trend?
It's still showing slide 2. Graphs are not. Just put down your cursor. You put in presentation mode, madam, like full screen.
Yeah, this is a presentation mode only.
But we can see the slides left side, all slides, like icons.
Okay.
So F5, can you press F5 on keyboard?
In my screen, I don't know what's happening. In my screen, it's reflecting that my presentation mode is on.
Okay, ma'am. Reshare your PPT and continue, please.
Just a second, I'm trying to.
Yeah, madam. Now slide 3 is visible. Please continue.
Slide 3 is visible now. Is it in presentation mode or no?
No, still in yes.
But if I now, can you see?
Click that. No, still. Please continue, madam. please.
Can I continue in that mode? I don't know, because in my screen it's showing that I'm in my slide mode. Like in my screen, it's not reflecting.
Yes, we are still at slide 3. Yes, now it is showing full screen.
The graph?
Yes, yes. Now full screen mode.
Okay.
Yeah, continue, please.
So, yeah, so I'm so sorry for the inconvenience. I don't know why it's happening. So the rising, so this is the graph from the CDC. I imported from the CDC, which is showing the rising trend of the breast cancer among young females over the past 20 years, especially the females who are less than 45 years. And we can see that in every race it is rising. However, there is another additional layer, which I talked about, that it adds, because the trend is not uniform all across the races. Did it move on to the next slide?
Yes, madam. Yes, it's moving now. Please.
Okay. So now, as we see that, and when we talk about the mortality, again, the trends are increasing. Have been increased recently, and among the young females. And again, we can see that there is disparity when blacks, non-Hispanic blacks, are significantly affected with the mortality with breast cancer in the young age group. Now, if you see the global burden, if you talk about, so right now I was presenting the CDC data, which was mostly for the US population. When we talk about the global burden, again, it definitely, in the internationally also, the breast cancer remains a significant contributor. And they also show multiple anatomical sites where we need to prioritize the young individuals, and especially in case of the breast cancer. We have the prevention treatment, since it is recently a topic of debate that should we include screening strategies for younger age group. So it's like a cost benefit issue that is happening if we incorporate screening strategies for younger age group. So that is also a debate going on, and because of that reason, many of the young adults they have a missed opportunity of getting screened and getting an early detection of the cancer. Now, the very important, this is like one of the most important slide, is why do we think that young women need tailored breast cancer care? Why is it important for them? So as I'm again reiterating that, again, the screening gaps that is present in this age group, the psychosocial stress, because these women have, by saying psychosocial stress, we do not mean that we are saying that the older women do not have psychosocial stress, but the additional level of stress that the young females have, which is because of the family, because of their profession, and because they are in their very prime age. So that adds the psychosocial stress, like fertility, work, emotional burden. Then there is genetic risk. Most of the time, the young females who are diagnosed, they have BRCA1/2 mutations, and because of most of the women who are diagnosed in young, they are often diagnosed in late stage, or the prognosis is really poor because many of them are triple negative. Many of them have triple negative breast cancer. When we talk about modifiable risk factors, which we think can be a contributory risk factor for females of young age group that are leading to this, is many of us are choosing to have late child. Lifestyle changes, dietary changes, obesity, they can affect the prognosis as well. However, these things are not typically limited to a young age group, because they can be contributory to the old age group as well. However, special focus from the starting, if we put the special focus from the starting in this age group, it might help. But again, if we talk about genetic factors contributing, then we might need to think about some other preventative strategies for younger females. And then access and focus gaps. Treatment programs often prioritize older women. Again, I said that all the screening programs, and most of the time, if you go to the provider also, most of the time, when we say cancer, our mind shifts to an older age group and we tend to rule out, we tend to put less focus when it comes to cancer, especially in younger age groups, which leads to late diagnosis of disease in them. Now, what are the barriers? What can be the barriers which lead to late detection, which are affecting the early detection in the younger women? So sometimes in the imaging, you do not get they are not very sensitive. In younger age group, the mammography, the imaging is not very sensitive, and it cannot tell you a lot whether it's there is cancer or not. It's not very sensitive for them. That is the reason why the age group was set to 45 before, and now they have dropped down to 40, and it's not coming below that. Then late presentation, because sometimes young women are not aware, and again, they are maybe ignorant of the fact that yes, they can have breast cancer at a very young stage. So their mind doesn't go that way. They're not very aware of the fact that how they should report any symptom or signs. Then there is stigma. Females with breast cancer have known to suffer from mental disorders like depression, anxiety, because of the societal stigma that is attached to females who have breast cancer. Then sometimes provider dismissal as well. Like if a young female goes with some kind of breast pain or lump in the breast, many a times provider, because there are many other things which can lead to symptoms involving the breast. So most of the time, provider focus also shifts to those diagnoses rather than breast cancer. So that can also be a gap which can lead to late diagnosis. And then access and cost. Breast cancer itself, the treatment is costly, is not very cost effective, and especially in this age group when they have a lot of baggage with them, when they have to deal with a lot of things. This is an additional cost, and especially in the reproductive and the working women who have to go for their work every day. And imagine they are told that, okay, you are going to get chemotherapy every week or every month. It's very difficult for them to take out time from work and then take care of their children. Education. Now, how we can deal with this, I will also put more focus in the later slides, how we can deal with this situation in the younger age group. Now, what are the other things that I'm trying to pinpoint the main issues which are there with the young females is fertility concerns is one. If you give them chemotherapy, they are known to cause fertility issues, the treatment for the breast cancer. And then the treatments are very aggressive and they can lead a lot of side effects, and which can lead to poor quality of life for these women later on. However, we do have good chemotherapeutics now, which do not cause a lot of side effects, but still till the period of time you're getting the drug, the lifestyle, the quality of life might deteriorate. Then I did talk about emotional and mental health, anxiety and depression that the females of young age group are having who are diagnosed with breast cancer. Relationships and motherhood. Women of this age group are they fall in the reproductive age group, and they have children who are on an average an age of 5 or 6 years, and they need special attention from their mother. So that is again a challenge for them. Career and workplace, especially this is the time when you are very active in your career, and so that also affects them a lot. And as I said, that most of the women who are diagnosed in their early stage have a more severe breast cancer because they're generally diagnosed with triple negative, and so it's even an issue for them. Now, what we can do as a preventive specialist, what recommendation and what things we can advocate is healthy lifestyle is one of them. But again, I said that healthy lifestyle is not the only contributory factor when we are talking about the cancer in young females. Definitely the genetic factors and the receptors, they all play a great role. So what we can do is to always assess the family history of a woman who is complaining dealing with breast cancer, any sign and symptoms which are related to breast cancer, to always assess their family history. If anyone if anyone in their family had any gynecological cancer, to always test women for maybe the mutations. I know it is not very cost-effective method, especially when we talk about lower socioeconomic status or where in a resource-poor setting, it's not always possible to test a BRCA mutation. But yeah, if we can think on those lines, it might benefit and help in early detection. Again, as I said, genetic counseling and testing. Healthcare professionals need to be educated, especially not at the physician level, but also at the community health worker level, how to identify such cases and and it's tough. It's definitely tough. You cannot, because the symptoms are mimicked by so many other conditions, which can lead to hormonal changes, can lead to it. Your menstrual cycle can lead to it. So there are definitely many other things which can contribute to sign and symptoms in the breast. So it's tough, but maybe identifying such cases and then referring them to the physicians so that they can have a deeper look of the case can be implemented. Risk-based screening is another thing that many advocates are telling, that many physicians are saying that we might do a risk-based screening. Like, for example, if you have a family history, if you are at high risk, if there are some other things which are attached to you, then in that case, we might recommend them, okay, let's just do a mammogram for them. But universal screening for females who are less than 40 years is still not feasible, because the disease is not that prevalent in this age group. And also, it might be a cost issue if we include such screening. And also, the psychological effect of doing this screening at an early stage can also not be ignored. Now, these are some of the call to action. Is again, the same things have been replicated here, as to promote, enhance community support. Especially these days, I've seen that there are a lot of groups, social groups, which provide psychological support to such women, and it's very important that women are connected with these groups. And even before the diagnosis of the breast cancer, just to create awareness, there are various breast cancer awareness groups as well, where young women can join, can participate, can volunteer. Risk-based screenings, again, it can be advocated. I know it's still a debate whether it's effective, whether it should be promoted because of the issues that I've mentioned. Then there should be, as I said, that sometimes your physician might not be the first person who comes in your contact, and we need a strong community support in the form of community health workers and social workers, and other breast cancer survivors, so that they are able to detect any kind of they are able to help in early detection of the cancers, and there is a strong connection with the oncologist and the social worker or psychosocial services, so that easy referral and quick referrals can help in early detection. Again, the last point is, it's very important right now to attend to the unique needs of these young females, because they have various domains attached to them, especially in this young age group of less than 45 or less than 40 years. And separate health professionals or separate different unique cares will be needed to deal with such a situation. I think that's all from my side. So this is just the introduction, or just the very basic information, and I just wanted to, because I'm reading a lot of literature on breast cancer in young females, so I really wanted to bring this topic up up as a keynote speaker, that it's really important for maybe all of us to just read about this and learn about this and create awareness about this as health professionals. And I will be devoting my another 1 or 2 years. I've just started in this area, and I'll be devoting my another 1 or 2 years in this topic. And let's see what results we get and what all policies and advocacies we can generate. Thank you. And sorry for the interruption. I'm happy to take any questions if there are.
Thank you very much, Dr. Pant, for your lucid and insightful lecture presentation. We are glad to have with us. Any questions from the audience? Any contributions or questions?
Thank you very much. My question would be the contribution to the diagnosis and the definition of cases, especially young women who are considered. The use of mammography, the definition of the data, because every research always have the data profile. So I don't know if at any point consider as one of the key tests for selecting your subject.
I'm sorry, I was not able to hear the entire question. If somebody can repeat that for me.
I want just to find out if the criteria of selection of subject for breast cancer, you are also using mammography as a
It's not audible to me. If the person who's hosting can they can repeat the question for me. Yeah.
Yeah, madam. He's asking about the mammography as one of the key objectives, like that. The significance of mammography as one of the key objectives to screen the breast cancer, like that. His contribution, like that. He's saying that mammography.
Okay, yeah, definitely. For the screening, we use mammography, but that is right now for current guidelines. It says that earlier it was 45 years. Women who were more than 45 years were screened for it. And after every 3 years, they used to get screened for it. Now they have decreased the age to 40. So definitely mammography is a tool which we use for screening. But when we talk about younger age groups, as I told, that there's a dense breast tissue is a difficulty in them, and it's difficult to. The mammography is not very sensitive and specific for this age group, and it might not give us a very good. It cannot be used as a main screening strategy in this case. Saying this, we still use mammography if we suspect breast cancer in a female or of a younger age group. That is definitely the first thing that we do in this age group. But yeah, again, we cannot promote it as a universal screening especially for women who are less than 40 years of age. I don't know whether that answers the question.
Yeah, thank you very much for that.
Any more questions or contributions? Yeah, thank you very much, madam, Dr. Niharika Pant, for joining with us.
Thank you.
Right?
Thank you so
Thank
much.
you so
Thank
much.
you.
Hello?
So, madam, can you start your presentation quickly? They're about to end.
Sorry?
Please share full screen.
Okay.
Yeah. Next. Like presentation mode. Not that one, madam. The screen. Yes. Not Zoom, madam. Screen. Next one. Right. Yes. Continue, madam.
Okay. Am I audible?
Yes, please continue.
All right. Thank you so much for the opportunity. My name is Triga Mtintamachona from the Department of Public Health, Texila American University. So my background, before I go to my background, the title of my presentation is Analysis of the Effectiveness of Malaria Surveillance Systems in Snazongwe District, Zambia. Under the background, malaria remains a major public health problem in Zambia. And also it's brought a high burden and has persisted in this form in rural districts like Snazongwe. Surveillance, however, is essential for early detection and response. Limited evidence on district level system effectiveness has been shown. Hence the reason why the study was undertaken. So under methodology, pardon me, before the methodology, we're going to look at a part that was omitted, which is the objectives of the study. One was to analyze the effectiveness of malaria surveillance systems in Snazongwe district, Zambia, as our general objective. Then the specific objectives were to assess for accuracy of malaria surveillance data in Snazongwe district. Then also went on to assess the timeliness of malaria surveillance report submission in a Snazongwe district. Also utilization of malaria data in planning and also decision making. Therefore, the methodology was as follows. Descriptive cross-sectional mixed methods was the design used. Then a population of 384 health workers were surveyed. Key informant interviews with district officials was also done. Then for quantitative data, SPSS analysis was used and also in vivo for qualitative analysis. Under results, we assessed data accuracy based on the accuracy of the reports. So the results show that 82% of malaria cases were confirmed. I must add, under accuracy, we base our assessments on completeness of the reports, then also diagnostic confirmation rate and consistency between facility registers and HIMSS submission. So under confirmation, results showed that 82% of malaria cases were confirmed using RDT or microscopy. And then under completeness, approximately 84% of facilities had submitted reports, at least with moderate completeness. Then 15% reviewed that the facilities had failed to meet the minimum reporting standards. Then the reason that was reviewed from the interviews of key informants personnel were that our reporting forms were out of stock from time to time, especially those facilities who had no power, meaning they had no capabilities to print their own reporting forms. And then also overburdened staff during the peak malaria seasons. Then under diagnostic confirmations, the findings showed that 82% of malaria cases reported in the previous cohort had been laboratory confirmed using microscope or RDT, while 18% of the cases were diagnosed clinically. The reasons that led to this, the report reviewed to say that it's because of RDT stockouts at the facilities, and also shortages in terms of staffing levels, which led to overburden of the available staffing. Then under consistency, it shows that 8.4 discrepancy rate was noted in the report between the facility reports and also the facility reports from the registers and also the HIMSS reports at district level. Under timelines, it showed a steady decline from 61% from month 1, and by month 4, it had dropped to 42.5%. And this was attributed to workload and delayed data validation. Under data utilization, the results showed that only 25.3% of surveillance data was utilized during decision making and also planning, and also in the response programs in the control of malaria. Under conclusion and recommendations, as we heard that the challenges mostly were due to lack of supplies, lack of training, and also shortages of facilities and delayed feedback. So the surveillance system revealed that it was partially effective in Sinazongwe district. Then there was need to strengthen training and system feedback in order to enhance timely reports and also quality of malaria surveillance data, which can in turn help improve the malaria control and eventually help in the elimination goal by 2030. Thank you so much.
Thank you so much. Are there any questions from the audience?
Good afternoon, madam. Madam Tita, are you able to get me? Madam Tita, are you able to get me? Hello? Miss Machona, are you still there? Unmute your mic in case you're speaking. Unmute your mic.
Yes, I can hear you.
All right, thank you so much. Your presentation is on the analysis of the effectiveness of malaria surveillance systems in Zambia district, right?
Yes.
So I was following your presentation, and I could not see any statistical analysis in terms of how effective malaria interventions were before the introduction of these systems, and after, for you to come up with an inference to say these were the surveillance systems. Hello, are you getting me?
Hello, sir. I can't hear you.
Now? You can hear me?
Hello.
Hello? Hello?
Hello, sir. Hello?
Okay, it's fine. I think you can get us. We have a network challenge. It's fine. Thank you.
Kindly type in the...
Okay, thank you so much. Yeah, I think we're having some technical challenge. At this moment, we are almost coming to the close of this wonderful conference. At this point, I want to invite the DVC to the front.
Three tracks parallelly. Okay, so I can see like the vibe from all the people who are sitting, the way they are asking questions. So this encourages us to think like still more like better way for the upcoming like years. Thanks for your participation. We personally thank to the associations like Public Health Association, Zambia Medical Association, like Zambia Zuno, Union of Nursing, and the president is with us for past like secretary is with us for past 2 days. So this is the contribution from their end for the development of nation. We really appreciate you. Thank you so much for your contributions, sir.
Well, very great presentation.
So in this occasion, like before going for the closing remarks, just to need to have like 1 or 2 feedbacks from our chairpersons, like who have helped us to session the test for last 2 days. They're with us, and also 1 or 2 participants, maybe like give the feedback, like where we want to improve. We don't want appreciations, we want to improve where we want to improve. That's the language we have. That is where we are standing. Okay. Thank you. This occasion is like I kindly request like the president of Zuno help us to like give some short note and like his experience.
Thank you. Thank you so much. Yeah. I recognize the VC and the dignitaries in front there. I think from our part as Zambia Union of Nurses and Midwives Organization, I think this conference has been a great one for us because to see the International Conference on Health and Allied Sciences probably is the first of its kind in Zambia, and we are happy that Texila, being one of the universities that we collaborate with, it's actually a plus even for us and to our members who are also part of this journey of being a Texila. We know that most of our members are actually students of Texila, and we are proud to see that the university is actually able to host such a huge conference. This is not an easy task actually to host such an international conference. And we look forward to more of such conferences. I know for it being the first of its kind, the next one probably will be bigger than this. And you might even consider to have a very big auditorium to host the next participants in the coming conference. So I think for us, we should say thank you for being also for being part of this journey, and we'll be with you whenever collaboration is needed. And like today we had a very good meeting with the VC, and we discussed a lot concerning some of the programs that our members and other healthcare personnel would like to see Texila. And looking at the state of arts of the skills labs that you have here, the computer lab and other labs that you have, I think we've gone in various institutions. I think you've got a very good infrastructure here, and we know that you are planning on developing it more. So we are very happy to associate ourselves with yourselves, such a university. Thank you so much.
Thank you for your encouragement, sir. Thank you so much. Just quickly, like from Public Health Association.
Thank you so much. Good afternoon, everyone. On behalf of the Public Health Association of Zambia, we'd like to take this privilege to thank Texila American University Zambia for taking this initiative of coming up with this important conference and for inviting our association to be a part of this great and innovative program. We can see that Texila actually is leading in a lot of innovative programs that we've never seen in our country since time immemorial. And we are so happy that actually academia, practice, and policy are coming into signages where we can actually put all our efforts together and work together to make sure that our Zambia becomes a better place for people to live and thrive again. At this point in time, allow me to share my heartfelt gratitude to the management of Texila for coming up with such kind of a beautiful program. And I think as we are listening to the presentations, we learned a lot, not only us getting the mistakes or the credits, but actually it is about knowledge sharing. Because everybody who knows something learns from someone. We're not here to compete, but we're here to collaborate and to share our ideas, because our goal is equal, to see a better Zambia tomorrow. So that tomorrow we can leave our Zambia better than we found it the day that we actually came to this world. Otherwise, we appreciate and we look forward to more conferences and to more interactions. Should we not be there in leadership even tomorrow, but at least this vision should not die. All these collaborations, and we look forward to more interactions and to more collaborations. Thank you so much, Texila. Thank you so much, everybody else who came to participate in this important event. Thank you.
Thank you so much. Next, I invite Brigadier General Dr. Lasan Simabufa. He's our mentor who is supporting us all the way we are progressing. So just give a closing remarks for us.
Good afternoon, ladies and gentlemen. I know it has been a long 2 days, but full of I can't subtract from my 2 colleagues as council and our public health association of them. I would have loved to give my closing remarks off the cuff, but being a military man, I don't want to be misquoted. Therefore, closing, I'd love to take cognizance of the Vice Chancellor, who is a brother and a very close colleague. We've been together for a long time. The DVC, the 2 deans, brother, Dean of School of Medicine, and my brother, Dean of School of Public Health. I met the Dean of School of Public Health when we were 20 years old at campus. And he was my neighbor. I was in Interforum 1, he was in Interforum 2. The rest is history. So, dear colleagues, distinguished guests, esteemed scholars, delegates, the sponsors, ladies and gentlemen, it is a great honor to address you on this momentous occasion as we conclude the International Conference on Health and Allied Sciences, hosted by the prestigious Texila American University Zambia. Over the past 2 days, we have witnessed a remarkable convergence of intellect, innovation, and vision. An assembly of leading experts, local and international, as you saw, early career researchers, educators, and practitioners, all committed to advancing global health. This conference has provided a dynamic platform for sharing cutting-edge scientific knowledge, best practices, and emerging trends across
across health and allied sciences. We have engaged in thoughtful discussions, rigorous debates, collaborative reflections on some of the most pressing challenges for our time, ranging from public health, preparedness, biomedical innovation, digital health information, areas of clinical research, healthcare management, and strengthening of health systems. The diversity of perspectives presented here from academia, institutions, public, international partners has not only enriched our conversations, but also underscored the importance of multidisciplinary collaboration, creating sustainable solutions for complex health issues. As we gather here for the valedictory ceremony, we celebrate not merely the end of a conference, but the beginning of new partnerships, renewed commitments, and expanded horizons. Each presentation, each dialogue, and each shared experience has added value to our collective pursuit of excellence in health sciences and healthcare delivery and indeed management. To the organizers, colleagues, faculty, the leadership of Texila American University Zambia, we extend our profound appreciation for your vision, professionalism, and meticulous planning. Yesterday, I was telling the Dean of Medicine that this is an A+ kind of grade. Your commitments to advancing education, research, and professional development once again has been demonstrated through this world-class event. To the keynote speakers, presenters, and panelists, we thank you for your thoughtful and insightful contributions, for sharing the depth of your expertise. To the participants and delegates from various countries, those presented, your desire, curiosity, and dedication have made this conference truly global in terms of impact. As we close this significant gathering, I urge all of us to carry forward the momentum generated here. Let us continue to champion research that improves health outcomes, innovations that transform practice, and collaboration that strengthen health systems across nations. May the connections formed here flourish, and may the knowledge exchanged today inspire breakthroughs that improve lives, not only in our communities, but across the globe. On behalf of the conference committee, I congratulate all contributors and extend my best wishes for your continued professional success. We look forward to meeting again, probably next year. I think the deans and the DVC will come for another conference, maybe better than this one, but I'm very positive it will be better than this one, as Texila American University is known to be always on top of things that has been alluded to by my two colleagues. Therefore, we look for collective work towards a healthy and a more equitable world. Thank you and wish you God's blessing. Thank you very much.
Just there's a certificate distribution. Which I request is not for all the presenters. We are sending e-certificates. Yes, I said beginning. This is a like giving for mostly we are sending e-certificates. So whoever physically came here, the shades, and also whoever presented the posters, they have some certificates, legal copies for documentation purpose. Okay, still you are looking for these certificates for the same one. So I'm requesting Ms. Nisa to read out the names. I request our Vice Chancellor Dean to help us to like issue the certificate.
When you hear your name, please kindly stand up and you come and speak the high table and collect your certificate. Certificate of presentation, physical presentation, goes to Jairus Banda.
Okay.
Next certificate of presentation goes to Ethel Mutemba. Person is Barbara Nasha. Followed by Dr. Janet Mlenga Muyunda. Milimo Hamukombo. Followed by Dr. Ali Kalambe Ilunga. Matola. For the following, there are no certificates. When you hear your name, you just come and greet the panel for the best. So the best presentation from School of Medicine was awarded to Monica Chirwa. Best presentation from School of Public Health was awarded to Dr. Janet Mlenga Miunda. The best presenter from School of Business Management goes to Dr. Pooja Gupta. And best presenter from the School of Informatics and Technology goes to Mr. Osita John Diana. Then for best poster presentation goes to Dr. Chimka Mwanga. Thank you. Sorry, just an oversight. We left off one presenter that was here physically. I don't know how that happened. Mtale Chanda. A certificate before you go. Thank you, High Table.
Thank you once again to all of you. So we are hearing the closing. I'm requesting our Vice Chancellor, Professor Rajay Kodak, to give the closing remark of the team. And finally, close, official close shall be a word of thanks will be done by Professor Patrick.
Thank you, Dr. Bala. It's a little difficult for me to speak sitting. I'm not very wise as Dr. Bala. I need to stand. So, it was wonderful that 2 days of intellectual deliberation we have now come to a close. But let me tell you, as a Vice Chancellor of the Texila American University, and on behalf of the Texila Board, our President, our Executive Vice President, and the other officers at the corporate level, this conference is not going to be just one conference and it has been finished. This is beginning of the series of the conference. As the president of ZUNO and the Public Health Association has said, that it should not be the only conference. Let me give you the assurance to all the stakeholders that it will be continuing and we will be backing next year with the much more glittering, much more mammoth, and much more intellectual conference. My dear participants, I am bit confident that this conference might have opened some of the new perspective to see the new ideas which can be valuable for the mankind, which can be good for the society, and which can be good for our future lives. I am very happy that this conference has got around more than 100 papers, and we have presented and got evident to more than 90% of the paper have been presented. This conference is, as you might have been seeing, that it is not a small conference. It is not an easy kind of thing to do this conference and bringing the international and national people together and doing it in such a smooth and effective way. This is a result of our admin team, our academic fraternity, who have brought all those kind of things in such a way that this conference has become a memorable conference in our lives. I congratulate each and everybody out here, whether it is Texila American University officials or participants, all stakeholders, our sponsors, and our supporters, coordinators, and everything. Thank you very much.
Thank you so much, sir. I request Professor Patrick Chanda to come and give a word of thanks to the stakeholders, volunteers, the people who made the success story of this conference for today's. Please welcome, sir.
There because of feedback, but also when we were young men, as the general mentioned, I was a preacher. Deputy preacher. So unlike the general, I have no fear of being escorted. Preachers don't fear being escorted. Okay, I think first of all, the Vice Chancellor, Deputy Vice Chancellor, Brigadier General, Professor, also too many titles, but there you are, the Dean of School of Medicine. I want to acknowledge also the presence of Dean School of Medicine from where is it? Here, the whole day. Okay, and thank you for your support. Okay, the ZUNO Public Health Association, our sponsors, without them, this event would have not been possible. To Zanaco Bank, to Airlink. Okay. I want to mention the people I might forget about first, so that I don't forget. The volunteers, the students, the representative council, that worked so hard in this conference, actually catering and many other things. I want to thank our hosts, Cheryl Guidance, for hosting us. I want to thank the technical people. We will agree, all of you, that this has been a success beyond our expectations. Okay? it's not easy to be linking up with people from all over the world. And our technical people did a tremendous job. There may have been some glitches, but overall, I think it is a job well done. I want to thank all the participants, those that have, especially those that have come to present in person, but also those that joined us virtually. Thank you very much. As you have noticed, I was very passionate about poster presentations. And I want to thank all the poster presenters who came to showcase their work through posters. Some of them are from here within Zambia, but there are quite a few who have traveled afar, Livingstone. Kasama is from Lusaka. More than 800 kilometers. Oh my God. Thank you. Thank you. I want to thank the local researchers who have showcased their work today. And I think the support team under the direction of the Vice Chancellor, administration, logistics. So I want to show appreciation to them as well. They are too numerous to mention. Okay? It is politicians who say too numerous to mention. But there you are. We can borrow words from politicians. We just want to thank everyone. Okay? I also want to thank me.
You are also included in everyone. Patrick, give the thanks to the global organization.
Yes. But before that, the local organizing committee and people who really worked hard to make this conference a success. Dr. Mlenga, Eddie Mlenga, the research coordinator. Naveen, Dr. Rajesh, Justin, the academic assistant to the DVC, Mr. Stanislas Chulu, the academic manager, School of Medicine. These people worked till late. In the last 3-4 days, it was not unusual for them to go home at around 21 hours or even 22. Okay, and so did everyone else who were preparing the venue and so on. So there was a lot of sacrifice that went into this effort, and we want to appreciate all that. Okay, want to thank faculty. Their contribution, in particular, recognize the efforts of ICHAS. Research from our student population. Okay, and I think you saw what was presented. It's really, really insightful. Okay, this is where I lose my memory. Maybe this is where I should stop. Okay. So thank you, everyone. Thank you for just being here. Thank you. Those suggestions you made, those comments you made in our planning meeting, those questions you raised, like Professor Zulu, always a sharp inquiring mind, they helped shape the destiny of this conference. And for that, we are truly, truly grateful. Okay? Now, let me just repeat something the Vice Chancellor said about certificates. We were able to hand out physical certificates, but getting your they call it virtual soft copy or the e-certificates. The e-certificates, all of you will be getting your e-certificates. You have to get permission from work and show, take it back and show them post. People say, don't blow your own trumpet, but who will? It's money. Okay, thank you so much, and God bless you. Those that are traveling back tonight, tomorrow, or over the weekend, safe journeys to wherever you are traveling. Thank you.
Thank you so much, Professor Chanda, for your acknowledgements and kind words. So, finally, like before saying thank you to all, like we need to appreciate like the total team of Texila American University and our partners. As Professor Chanda said, like support from our student side, faculty side. So we're really happy that it is a continuous like team success we are showing 2025. We have initiated like since the beginning of this year, we have achieved not in 2025. Yes, Vice Chancellor has quoted his speech yesterday also, like British Accreditation Council is a ground for Texila American University, the first university in SADC region, which has been medical university, which has been recognized as a independent higher education institution. Okay. So we are the number one for that one. We are always having proud of that one, all our operations. That is number two, like the same way we have worked for the same, like how we have worked for the conference, the same team, like we have contributed well, we achieved it. Still we are trying for the upcoming years. With this, thanks everyone for your wonderful time and support. Thank you so much. Thank you, sir. We request everyone join with us to take a group picture in the down floor. Then we will leave. Thank you so much.
Hello, sir. Kids, they have to receive the gift.
Hello. There is a small announcement. The presenters who came here registered and presented the paper. Please, like once after the group pictures, please come to the conference secretary TVC office. We have some conference kits for you. Please collect for the people. Okay, who have presented the paper, who got certificate, please visit us our office.
Madam B, this important event.